5 years ago, I think our allocation was about 24, 23%. A lot of work has gone in, a lot of advocacy, a lot of capacity building. And right now we are doing an average of 28%.
For Busia, as of now, the county government has allowed us to execute 30% of its total budget. At least we are doing at around 30%, slightly above 2.5 billion, above 2 billion shillings.
Sometime last year, when we were having an engagement with the HP Plus, we managed to be taken through an analysis of the vote book and the standard chart of accounts. I'm happy, even the malaria focal person, the county malaria focal person, after our meeting, he was able to go to the budget document. He secured his malaria funding and they were able to buy microscopes.
So we noticed that the percentage of facilities that were doing microscopy were very few. So of the 3 million, we said we are not going to do anything else. We are going to do microscopy first, so that we have got 13 facilities that are not doing microscopy to start doing microscopy.
We were able to test or to capture patients who had malaria, Plasmodium malaria, and Plasmodium ovale. And so I think now the clinician could treat the correct thing. Because before they were missing it out, because MRDT cannot detect the 2 Plasmodium species. And also at the same time, with microscopy, we normally do quantification. So it is easier to detect a patient with severe malaria through quantification. And also you can do a follow-up by quantifying to assess whether this patient is responding to the drug that has been given or he's not responding.
So that training opened our eyes. We've always been losing our money because we're not executing the budget the way it's supposed to.
Good morning once more. I hope you're all keeping well. Yes, so my name is Emily Macharia. I'm a Senior Program Officer with Health Policy Plus, and I'll be taking you through the agenda for today. First is to welcome you all to our meeting. We are very glad and honored that you found the time to join us today. So before we go into the details of our agenda, we wish to acknowledge our different teams that are with us today. We wish to acknowledge even our online participants who could not make it to join us in person, but they are with us in the our different online platforms. So to start off, we wish to recognize the presence of the Ministry of Health, with the leadership, the different departments, the divisions, the programs that are represented in our meeting today. Thank you so much for joining us. We also wish to recognize other government agencies that are present with us today. Thank you so much for finding the time to join us. With us today, we also have our stakeholders from the county. We also have a representation from the Council of Governors, as well as the leadership of the CEC Health Caucus. So we are very glad that you all found the time to join us today. Thank you so much to our colleagues from our different projects in Palladium who've made their time to join us today. We also wish to recognize our former colleagues with whom we implemented with our project. And so that said, I wish to also recognize our global leadership team led by Dr. Sunita Sharma and the DC delegation. Thank you for joining us in our meeting today, and welcome to our country and to our city, and most importantly to our event. So that said, allow me to take you through the agenda of the day. So kindly have that on the screen. Okay, so today we have the opportunity to look back and reflect on our journey as Health Policy Plus, reflect on our achievements, on our project interventions as well. So to start us off, we'll have an opportunity to listen to key remarks from our guest speakers. Thereafter, our country director will take us through the project design, our implementation, our key achievements, and the process that we've gone through over our years of implementation. Thereafter, we'll have an opportunity to listen from a seasoned panel of experts that are going to delve into details regarding domestic resource mobilization. And after that, we'll have an opportunity to hear from our colleagues that we've worked together with, both at the county and at the national level. Towards the end of that, and over the course of our implementation, we have published a wide array of products, and it will not have been feasible for us to publish all of them, but on your desks, on your tables before you, you have a catalog. Please take some time to familiarize yourself with it. We are highlighting our key publications. We also have a QR code in there. You can scan that and it will lead you directly to the HP Plus website, where you'll be able to interact with our different products. At the end, at our pre-event lobby, we have some of the results that we have highlighted. Over coffee break, feel free to interact with those products. We'll have our technical team right there to take you through and also just give any explanations as needed. Finally, we also just wish to request our virtual participants to kindly put in their details online. We also have a team that is monitoring that platform, so feel free to interact with us. We'll be taking your questions as well, your comments over the course of the meeting. So as I conclude, we will be recording this session, and we'll also be expecting some broadcasting of the event as well. And aside from that, we will be sharing key highlights of the event on different social media platforms. So we do request you to kindly share any highlights from the event today. Kindly use the hashtags that are projected on your screen and are also towards the end of your agenda, tagging Health Policy Plus and USID Kenya. So that said, I wish to welcome our country director, Dr. David Haoya, to take us through the next session. Karibu sana, Daktari. Thank you.
Thank you very much, Emily. Good morning, ladies and gentlemen. Yeah, I think today is a day which I could describe as a cocktail, a day that is mixed with anxiety, excitement, as well as some soberness. And so this actually makes it very difficult for some of us because much as we are excited because of what we've achieved, we also are sorrow because we feel like we are exiting the stage. But I know that this world is a world which is round. When you see me living on one side, you can easily see me coming back on another side. So that's the beauty about going round the world, because you can, when you are at the back on one side, you can be at the front on the other side. But having said that, allow me to welcome our guests, whom we have invited to actually give us some opening remarks as we celebrate this day. This day to us, as I've mentioned, is a very important day because our focus is not really on what we have achieved, but how we achieved whatever we achieved, which is important. And the reason why it's important, because anybody else can actually utilize that knowledge to be able to implement activities across the country. And so for us, we will be focusing more on the approach as opposed to the results, because the results are there for us to see. We can see them anytime, but to be able to know how we attain those results to us is very, very important. So please allow me at this juncture to invite Dr. Sunita Sharma, who is our Global Project Director from HP Plus. She actually traveled all the way from US, and she has, because she's in charge of so many countries, She actually has been moving from one end of project event to another. And for this one, she just came from Nigeria. So welcome, Madam Sunita Sharma. Thank you.
Thank you, David. And really, EOP, as you mentioned, is not easy. It's really excitement to share great results, but at the same time, really thinking about the project is ending. But I'm so pleased to be here today, and I would like to acknowledge the kind presence of the CEO to the COG, represented by Regina Ombem, representatives from county health departments, the chair of CEC Health Caucus, Professor Richard Muga, the vice chair caucus, Dr. Ida Mahmood, the director of policy and planning at MOH, Mr. Stephen Macharia, and USAID mission. All protocols observed, ladies and gentlemen. Thank you for joining in person and online. And thank you for this valued partnership under Health Policy Plus, Kenya and East Africa. There is so much to celebrate together as we mark the conclusion of HP Plus Kenya and East Africa. I'm looking forward to hearing the details of many accomplishments reached together with our local partners, including national and county governments, civil society, universities, research organizations, and the private sector. Our work with the Ministry of Health has advanced health policy reform and sustainable financing strategies. Our capacity development collaboration with county health teams has helped them achieve better planning and budgeting, backed up with stronger skills to conduct analysis and advocacy efforts for securing additional resources for health. These impressive results are evident at both national and county levels. This work hasn't been easy, but the team moved it forward despite challenges during the past 2 years as they adapted to the global COVID-19 pandemic, including working through lockdowns. It has been my immense honor to be part of this team as I led the Health Policy Plus project for the last 7 years. I'm especially gratified that we have worked hand in hand with our USAID counterparts or USAID colleagues in Washington, DC, and most importantly, here with our Kenya mission representatives who helped guide our path. Policy work is the backbone of everything we do. Well-financed and functioning health systems, high-quality health service delivery, equitable access to health, improved health outcomes, transparency of information and data, it all can be traced back to policy. Policy matters. So HP Plus had a significant global impact. Worldwide, we have collaborated with nearly 1,700 partners across 49 countries to achieve more than 2,000 results. And when I'm talking about policy results, they're very high-level results. They're policies adopted, operationalized, domestic resources mobilized, efficiencies improved, governance structures created, and all these evidence-informed decision-making. So number of really high-level results we talk about. This includes the mobilization of over $465 million in domestic health resources and $1.4 billion mobilized by countries from Global Fund or other donors. We have supported development and implementation of 187 policies, including laws, regulations, strategies, operational policies. So at every step, HP Plus facilitated the achievement of these results with a focus on localization and capacity strengthening, and by following the lead of our local teams and partners. As we all hear today, evidence generated through our collaboration helped make the case for more than 219 million in domestic resource mobilized to fund commodities for HIV, family planning, and malaria in Kenya. Given the reliance on donor support to fund commodities, mobilization of these funds and further commitments as part of the MTEF process is a testament to government's response to preserving the gains made and strengthen the sustainability of funding for these commodities. Our collaboration also generated evidence that mobilized approximately 821 million from Global Fund. We are particularly proud to have provided technical assistance leading to the February launch of the 2020 to 2030 Kenya Health Financing Strategy. The launch signals the government's commitment to reform the health sector and achieve sustainable, high-quality services for all Kenyans. With a commitment to equity and access, the strategy provides the framework for domestic resource mobilization, including expanding health insurance coverage for Kenyans as a measure towards achieving universal health coverage. And this will be a true game changer for Kenya. So our support at the county level has been very critical in strengthening DRM for health, as well as strengthening local capacity in planning and budgeting, evidence generation and use. As you know, use is very important. How we interpret data, how we analyze it, how we really informing decision making. If we make right decision, chances are high that we'll have really impressive results. So, and always when we are working in different counties, we know that each county, the issues we address are unique, or different countries we work, issues are unique. But HP Plus approach has always been to listen, learn, and adapt tools and approaches to support the goals that you set with your partners, and to do work with you to ensure they are appropriate, built for Kenya, locally owned, and sustainable. So today, like you, I'm looking forward to celebrating with David and his team as we shine a light on our partnership in Kenya. And I'm really thankful to USAID for the opportunity to work in Kenya. It has been a great experience for us. We highly appreciate government's leadership and really chance to work together, which is good for all Kenyans. Thank you so much.
Yeah, thank you, Dr. Sunita Sharma. And you can now see why she's the global director for HP Plus. She understands every country. Sometimes she talks about things about Kenya until I'm like, let me counter check whether she's right, and I always find her right. So thank you very much, Sunita, for gracing this occasion. I think we really appreciate it. I know you came with other colleagues from DC. They are seated over there. We really appreciate that you are able to actually endure that long journey to come over and participate in this event. So to go to the next speaker, I think, as you know, Sunita has told you that we are just implementing partners, and we have our donor. And our donor is represented here today by Mr. Munguti from the USAID. I will welcome him to come and give his opening remarks. Mr. Munguti, please. Thank you.
Thank you so much, David. I think I know almost everyone in this room, but now I'm I'm representing USAID, and apologies to Washington, from Washington, and John Kinley, who is the Office Director for Health. Unfortunately, they had to attend. They were called for another meeting this morning, but we are there. So just to start off, I think the representatives of the Ministry of Health, Council of Governors, I can see them here, the County Executive Committee, I can see Dr. Muga here, the Health Caucus, the Health Policy Plus team, both from Washington and also from the country here. Donors represented here, and ladies and gentlemen, all protocols observed, good morning. Yeah, just to start with just setting the context, we know that USAID Global Health Agenda focuses on achieving 3 policy objectives. And one of these, preventing child and maternal deaths, controlling the HIV epidemic, and combating infectious diseases like malaria, tuberculosis, and other global health challenges. From our side, USAID, the overall policy objective as relates to the health system strengthening is to support partner countries to finance their own self-reliance and better engage the private sector solutions for advancing country progress. Now, in line with this policy objective, over the last, I think I would say 7 years, USAID has supported HP Plus, or Kenya's Health Policy Plus project, in advancing sustainable domestic financing for health and strategic public health programs. That's, I'm talking about HIV, TB, malaria, and family health, both in Kenya and in East Africa. It's a big project. So in Kenya, HP Plus mandate spans across national and county and subnational levels, basically to strengthening and advancing health policy priorities in HIV, family planning, reproductive health, and maternal health. And most recently, started supporting COVID-19 response. Towards this end, HP Plus project in Kenya has supported counties and the national government in building their capacities in health planning, budgeting, and evidence generation to inform policy, planning, and budgeting, as well as health financing reforms. Overall, from the engagements that HP Plus has been having with the local systems, that is both national and county level, the project has registered remarkable achievements, as the global project director has mentioned. Allow me to pinpoint some of the remarkable achievements that HP Plus recorded. One, there has been a gradual increase in government commitments to financing health from domestic sources. For instance, on average, over the planned period, that's from 2015, the proportion of government contribution to the health sector has increased from about 6.6% in fiscal year 2016 to about, let's say, 11% in 2020-21. Two, development of policy, and allow me just to highlight top level, development of policy and legal frameworks to fast-track UHC rollout in the country. And here we are talking about the Kenya Health Financing Strategy. As you are aware, I mean, the country since independence has not been having any whatsoever health financing strategy. And it's through the engagement of HP Plus that finally we managed to have a financing strategy for the country. I mean, to guide how resources will be mobilized, pooled, and allocated in the health sector in a most efficient way. There is also the issue of the reforms to the National Health Insurance Fund aimed at promoting increased access to affordable, equitable, and quality health services in the country. Three, there is also been remarkable contribution to evidence generation. I think that has already been mentioned. For instance, the evidence derived from the Kenya National Health Accounts, which I'm sure you have all seen it as you are coming in. That's a powerful resource which has propelled the health financing agenda to the highest level of policy and decision making. We've also, HP Plus has also supported the systems at both national to churn out public expenditure reviews that have really improved understanding of how health sector resources are being allocated and utilized. On the same, now I think these days out-of-pocket spending is a currency now in the household. And it is frequently mentioned in many of the health forums, and is being used to benchmark county performance, especially with respect to UHC. Now, four, and this is important also, we at USAID, Kenya and East Africa, appreciate the collaborative nature of HP Plus support, mirroring on our commitment to implementing programs through local organizations. To this point, HP Plus has worked with and through local partner institutions to build the local capacity for resilience and sustainability of the national and county health systems. For example, when we've worked, HP Plus has worked with has built the capacities of some of the local organizations like the Kenya School of Government, the University of Nairobi, which for the latter, they are taking lead in costing of HR services using the activity-based costing and management. The Kenya School of Government has also spearheaded and taken lead in capacity building of counties in planning and budgeting, focusing more on program-based budgeting. Good. We really appreciate the contributions and achievements of HP Plus in implementing real results within their field and in working to localize these efforts. So, ladies and gentlemen, with these few remarks, I wish you happy celebrations. Thank you.
Thank you very much, our donor. You know, sometimes the parents know the child better than the child themselves, so they are able to articulate everything about the child better than the child. So we really appreciate that you are able to see some contribution we've made as HP Plus, and we hope that we will continue collaborating. So I think, allow me also to mention here that we've not been working alone. As you've been told, we work at the subnational level in the counties, and you can't go and succeed in the counties without collaborating with the Council of Governors. And we invited the Council of Governors CEO, who actually was very gracious enough to nominate Ms. Regina Ombam to come and represent her. And we have a long history with Regina, so I don't want to explain so much because she knows us like at the back of her hand. So allow me to welcome Regina Ombam to come and represent the CEO of the COG. Thank you.
Thank you very much, David. I'll start off by saying good morning, everyone. You know, now I'm standing here as the CEO of COG, so I needed to be loud so that when I go back, I tell her the response was really good. Good morning, everyone. All protocols observed. On behalf, so I'm here representing the CEO Council of Governors, Ms. Mary Mwiti, who would not be with you this morning. And therefore, my work will be very easy, just to read what she wanted to communicate to you all. So all protocols observed. On behalf of the Council of Governors, I want to thank you for inviting me to speak at this closeout event. The Council of Governors is a non-partisan organization that is established under Section 19 of the Intergovernmental Relations Act, and it comprises of governors of the 47 counties with the main function of promoting visionary leadership, sharing best practices, offering collective voice on policy issues, promoting inter-county consultations, and also encouraging and initiating information sharing on the performance of county governments with regards to the execution of their functions. Noting that health is the backbone of every governance system, on health matters, a standing committee of governors deliberates on issues health, while the Council of Governors Secretariat, where I head, provides agenda, programs, and technical briefing to enable this committee perform its duties. So ladies and gentlemen, with the devolution of health, the need to shift focus to where action is, which is the county level, makes it vital for one to understand the state of the health systems in which health services are delivered in all the 47 counties. A good health system should be able to deliver effective and quality healthcare services to all in need without any financial hardship. Therefore, sustainable financing for health is one key aspect of our health system, and as the performance of the county health system is largely driven by finance. So with this understanding, I want to indicate here that the Council of Governors over the last 5 years has partnered with Health Policy Plus in addressing the following areas. 1, strengthening capacity of counties in planning and budgeting, and in particular, support has been given to counties through the program-based budgeting training curriculum developed jointly with the Kenya School of Government. The county staff now can attend this training at the Kenya School of Government so as to improve their skills on program-based budgeting as required by the Public Finance Management Act. In terms of looking into the future, it is important for us now to take this to the next level so that all the counties fully understand what it means in terms of effective planning and budgeting. 2, there is sensitization of the Council of Governors Secretariat, which has actually improved their understanding of the MTEF process. This is the medium-term expenditure framework budgeting process. In addition, HP Plus also supported the Secretariat to develop an MTEF monitoring tool that the COG administered to the counties to monitor their progress and adherence to the budgeting cycle. So going forward, this is something that we really need to take on so that we use it to, again, inform policy in terms of financing for health at county level. 3, supported the COG to undertake a capacity needs assessment for health products and technology. HP Plus facilitated meetings for HRH and Human Resources for Health and Health Financing Technical Working Groups, and also helped in preparing a brief on legal and structural barriers to funds flow to counties. I wish to report here that through this engagement, we have seen a lot of discussions and deliberations on ring fencing of county health funds for purposes of actually improving county health delivery systems. Also, finally, there are various evidence generation assignments like the national health accounts, assignments on health financing and UHC, assignments on costing that has improved members' understanding and interpretation of the key health financing concepts and issues. And this has actually helped to increase our negotiating power as COG when we are at the table. So as the COG Secretariat, we note and appreciate the USAID support in health system strengthening for the counties with the aim of making it sustainable and well-functioning so that counties deliver high-quality health care. So in fully understanding the instrumental role played by USAID in healthcare service delivery at county level through its implementing partners, COG has always provided a conduit for engagements between partners and the counties and will continue to do so. As a council, we remain hopeful for your continuous support and engagements. Thank you and God bless you.
Yeah, you will agree with me that the CEO nominated a very able representative who understands what we do, and so we really appreciate. Please also allow me now to welcome the chair of the CEC Health Caucus, ideally the owners of the Council of Governors, because we have heard from the Secretariat, now we want to hear from the owners. So Professor Richard Muga is the current chair of the CEC Health Caucus. Professor, you are welcome.
Thank you very much, Dr. Haoya, for the invitation. The Global Director, Sunita, our colleagues from the Ministry of Health, Dr. Macharia and Isabella, I can see you there. The representative of COG, and the funder, my friend Munguti from USAID. My colleagues from the different counties. Yesterday we traveled in the same plane from the city of Kisumu. I noticed you, and one of my very good officers in the past, Dr. Shikeli from Mombasa. I can see her sitting there. This morning, I was invited by Dr. Ahoya. Then I was debating, should I come or not? But then I remembered I have a vice chair from Mandera. So I gave him a call that in case I am not able to come, you will come. And then because we are in a process of succession, when you are invited to a meeting, go with your vice chair. So that tomorrow, he knows what to do. Rather than just going to Serena and enjoying yourself, then the day he comes, he doesn't know the footsteps. It's very tricky. So Dr. Eda is here, and I want to donate to him my 2 minutes to greet you. He comes from Mandera, And I asked him, is HP Plus working there? And he said, no. Then I said, this is the more reason why you must now come, so that they know that counties extend up to Mandera, and then up to Homa Bay, then up to Busia, then up to Kilifi. We are 47 of us, and we are 47 CCs. My friend, come and say something. He's a young minister, still has many years to be with you. Say something.
The project director, HP Plus, Dr. Sunita, the county director of HP Plus, development partners, CEO, COG representative, my chair, the chair of the CCOs, Dr. Shkeli, representatives of the Ministry of Health, health representatives from other counties, all participants in-house and online. Good morning again. I wish to take this opportunity to thank my chair very immensely for giving me these 2 minutes. I was to represent him. Now that he has come. Officially, I will really limit what I have to say. But let me start by saying that I really appreciate this invitation and interaction. And I'm also very proud that, on my back here is a photo that represents where I come from. Not only myself, but a lot of other counties, including my colleague from Turkana there. And we can see also we have Camel on the other side. So I'm very comfortable in this room. Just 1 or 2 things for me to say. One of the most fundamental things that has happened in Kenya is the ushering in of the 2010 Constitution that has fundamentally shifted how health is seen, and health is seen to also be functioning. So that devolved system of government, which gave the health sector, through Schedule 4 to the county governments, has tremendously, changed how health services is delivered in Kenya, along with the Bill of Rights. Now, as you know, all key pillars of health require financing, and different counties started from different places. When we play relay, when you see relay in the Olympics, there's someone who takes the inner lanes, others take the outer lane, some in the middle. So we have got counties that were in the inner lane. Their health systems were fairly refined and developed. And, I worked for 15 good years in Coast General Hospital under Dr. Shkeli. And when I went as a CEC to Mandera to go and find a county that had the 3rd worst global maternal mortality at 37.94 per 100,000 life bouts, only, better than Chad and Somalia, I knew we had a very hard task to do. But I wish to say that through the devolution itself and support of partners like, HP Plus and many others, and USAID, I can confidently report that in 2019, the data that was released by the national government just the other day, Mandera's maternal mortality is 385 per 100,000 life birth from 37.94 in 2013. That tells you the stride. So this would not have been possible if we did not have, very strong partners like, Palladium and USAID and many other partners. I would wish to stop here and say that any fruit that is ripe has got 2 functions. The first function is to nourish the person next to it. So in this case, USAID has grown Palladium through their assistance. The fruit is ripe. That ripeness of the fruit, the beneficiaries who have partaken the juices and the good nutritional aspect is the county government. So we say thank you very much. The second role of any fruit that is ripe is to make sure that the seed that is in it germinates to grow another tree. So I would wish to advocate for all the partners who have been funding Palladium to please make sure that you keep funding them so that they germinate and grow more trees. They have not reached my county. We have actually tried to change so many things in so many ways, but you know, we have not had that serious assistance. I will believe if Palladium will have been with us or other bigger funded, you know, partners that are usually scared of the North. The North is the place to be nowadays. So mine is to appeal, please come out of the center. We have started the relay journey of 2013 from very far. Our brothers have started from fairly ahead. So come to those that have been behind so that you know the tree is planted and that fruit is also felt in Mandera and beyond. Very many thanks, and thank you, Chair.
Thank you. My advice, you know, I was feeling now if I invited him and I don't give him a chance, then that is tricky. But you can see he has new insights. He's giving a good summary of what has gone on and what still remains to be done. I want to confess that I previously worked as the Director of Medical Services for Kenya for 5 years. And we did many things with USAID and many things with the World Bank. Mr. Muchiri there was our Chief of Planning when I was Director of Medical Services. And I had the chance to be in a Abuja meeting where Global Fund was born. And I had Sunita mention a lot of good things have gone on. But I want to say on behalf of the county government that yes, the partners who work with us under the COG, there is still a lot to be done. We have achieved many good steps. When I was Director of Medical Services, we started working on this document, the financing strategy. And every day we would try to present it and then it would be shot down. Finally, it was born, and now we have it on the table to try and guide the process that we have in. And then the issue of ring-fencing the local resources and the resources for health to be used in deliberately financing health. This is still a challenge. Why? Because the legal framework has been a challenge. In my county where I work, Homa Bay, we are just in the last step to pass regulations to be able to ring-fence the health funding. And I would want to encourage HP Plus, and I want to tell USAID that their mission is not finished. We still need another term because there is a lot of unfinished agenda. Munguti knows that we work together on this. Finally, it is on the table. We want to make sure it is implemented. And given the universal health coverage agenda, that the little money we get from NHIF can go to the counties and go to the facilities and support households. This is key for us as we move on. And the partners have to come now with new ideas on how to make it happen. The document is ready, but how do we make it happen? Many counties, including mine, we have good budgeting and planning. But when it comes to implementation, we are stuck. And as I talk today, my staff are on strike because their salary for April has not been paid. Why? Because we did not remit in time KRA, and KRA gave an order to stop everything. And so you can see the small issues which can stop counties from functioning. And so my colleague, Minister for Health, has gone to court again to undo the order so that the payment can go ahead. It is real. You may ask why, but the rest of the story we dig together when HP Plus is in Homa Bay. So there could be other counties which face the same challenge. And you see, recently we had COVID-19. And we in the counties, we have faced a big challenge. Many virtual meetings. You end up now with a vaccine, and households don't want the vaccine. They say, you told us to remove the mask. why do you want to vaccinate us? Another big challenge that the counties are facing. But devolution is the best thing which happened to Kenya. A lot of big achievement, like he has said, maternal mortality ratio in Mandera. When I was Director of Medical Services, that was the example we could give people. Mandera, the highest. But today, with a young minister, we are beginning to see success story. So, Madam Sunita, we want to indicate to you that the achievements of your efforts are beginning to bear fruits. Malaria has been a big burden for many of our counties. My county was having 30% malaria prevalence. Today, the latest malaria indicator survey brought it down to 3.6, meaning that the many deaths which we are having due to malaria we are going to prevent. But then, you may find cancer, you may find TB, you may find HIV/AIDS still catching up with us. So the work is not complete. And on behalf of the county CECs, I want to indicate that although you've called us to end term, we are looking forward to another meeting for a beginning of a new term. This is what we would say. Because if you exit and you don't enter again, then most of the good achievements will go to waste. And because of that, I want to ask by a show of hands how many counties are represented here. We were with Busia yesterday. I see Busia. And you? Kakamega? Kitui? Wow. Mandera? Mombasa? Migori? Kisumu, oh, the city, Afri-cities. Vihiga? Kilifi? Nyeri? Turkana? Nakuru. You can see, I saw another hand. Okay. Baringo? Mombasa? You can see a very well-attended meeting. And all these are key stakeholders. And on their behalf, I want to thank you for the good work that you have done in the past and invite you, through Munguti is looking down, when they put a new request, you need to remember that there is unfinished business so that we can continue to work together with the COG, the Ministry of Health, and the counties. And with that, ladies and gentlemen, we thank you for the invitation. Thank you.
Yeah, thank you, Prof, for advocating for us. I'm sure the donor has heard. He was looking down, but I'm sure he started looking up. Thank you very much. Yeah. So I think, ladies and gentlemen, we have been having opening remarks from our distinguished guests, and it's now time to get another keynote address from the Director of Planning from the Ministry of Health, who, after his speech, he will now officially open this meeting. As you know, those were opening remarks, but none of them opened the meeting. So let's now have the keynote speaker come to open our meeting. Thank you. Yeah.
Thank you very much, Director. And I want to start by welcoming you again to this meeting. You have been officially welcomed, but also as the chief guest, I also want to welcome you. And feel at home. This is a place that we have been working with the HP Plus for many years. And I want to assure you that we have been doing a good job so that we ensure that what Professor has said is sustained. So I have a speech that I want to read, but before that, I also want to say that I'm studying here as one of the people who have been working with HP+. And we have worked on many projects, but I'll be restricted to talk on behalf of now the ministry. So I think you'll miss my details about the projects, but I'm sure that they'll be mentioned by other speakers. So, ladies and gentlemen, all protocols observed, it is indeed my great pleasure and honor to be here today at this important meeting. This being the closing of the HP Plus project. And remember that in Kenya we are also having that transition of the political transition. The current government also is heading its term this year. We are also having a net term of the midterm plan for the Vision 2030. So I don't know what kind of coincidence it is, but I think it is good such that what Prof has just mentioned in terms of the transition, I think it would be very good that we start off with a new project, new government, new midterm plan for Vision 2030. And all that combined, I think we'll be able to achieve more even than what we have already achieved through the current project. As you are aware, the Kenya Constitution provides for the right to life and the highest attainable standard of health for all citizens, which includes the right to quality health care services. Through the long-term economic blueprint, Vision 2030, and its current third medium-term plan, the government has deliberately committed to undertake development processes to make Kenya a globally competitive middle-income country by 2030. As we now embark on the medium-term plan 4, beginning next year, we are trying to work hard to ensure that most of the strategic programs that we have in the Ministry of Health are also uplifted to become part of the flagship projects. And this is, I think, is the core of the HP Plus project that we have been implementing. You know, flagship projects, many people have been thinking that it is just a matter of construction, big buildings, big machines, but HP Plus has been at the core of implementation of UHC and also the strategic programs. And that is why we are also looking at that. I know Muguti has been with us in trying to draft the MTP4, and we are ensuring that we shall have those strategic programs uplifted into a flagship project to ensure attainment of UHC in the Vision 2030. Under the Vision 2030 social pillar, the government is committed to improve the quality of life for all Kenyans by ensuring equitable, affordable, and high-quality health care. The Kenya Health Policy for 2014-2030 gives direction to the health sector to ensure that significant improvement in the health status of Kenyans is achieved in line with the Constitution, the Vision 2030, and global commitments, including the Sustainable Development Goals. The government of Kenya greatly values the important role that partners play in helping it progress toward achieving these goals and commitments to our citizens. In particular, the government, through the Ministry of Health, greatly appreciates the contributions by partners in terms of financial resources, technical expertise and advice, capacity strengthening of our staff, and research and other evidence generation to inform decision making. While the government is fully committed to improving each of these areas, we do not always have all the resources that we need, and therefore the contributions that partners make is extremely useful. We are aware that we are currently in the era of the transition, the donor transitioning, whereby we are trying to see how we can sustain our programs through self-financing, but we still require the donor support because we cannot transit all the funding all the support that we have been receiving in one day. We still require the donor support. I'm particularly happy to note the contributions made through the partnership we have enjoyed with the USAID through the Health Policy Plus project. Since its launch in Kenya in 2016, I must also add that it was through the support and collaboration with the HP Plus predecessor, the Health Policy Project. I used to hear about the Health Policy Project before I joined the ministry, but I have been seeing documents that they had produced. So we also appreciate the contribution of that predecessor, especially the 2014 to 2030 Kenya Health Policy, which includes the overall policy framework within which the health sector operates. All other policy documents, strategic plans are anchored on the 2014-2030 health policy. We especially acknowledge the support given by HP Plus at a national level and also the county level. And I want to mention just some few areas that we have received tremendous support. One of the areas is on research and evidence generation. And through our collaboration with the HP Plus, the Ministry of Health has conducted several significant studies that have been guiding critical policy decisions. The studies includes the national and county budget analysis. I'm sure you have seen one of the documents there at the entrance. And then there is also the estimation of the national health accounts, which we have just concluded some few months ago. We also have the ongoing ABCM costing for the essential programs. And these are some of the areas that are still work in progress, as has been said. And we still need, as the director said, the word going round. It should come out in another way and support the ABC so that we also implement it and we also institutionalize the ABC within our own institutions. Contribution of technical expertise and advice. The Ministry of Health has also benefited greatly from HP Plus technical expertise in many areas, and especially on how we finance our healthcare systems. HP Plus played a pivotal role in the development of the Kenya Health Financing Strategy, which has been displayed by a professor. And then we also made significant contributions to other initiatives, both at national and county levels, including the redesigning of the Leader Mama Free Maternity Services Program. We have had experiences from Mandera, where the maternal mortality ratio has gone down, and we might think that some of these initiatives could have contributed towards lowering some of these indicators. In terms of capacity building for our staff, we are greatly appreciative to the USAID-led approach to ensure that there is highly skilled local capacity to support the delivery of excellent health services to Kenyans. HP Plus has contributed immensely to the government efforts, to the staff that are well able to plan and budget appropriately, as well as identify and mobilize additional resources for healthcare. In particular, HP Plus, in collaboration with the Kenya School of Government, assisted the Ministry of Health to devise a curriculum and training program for national and county health staff on program-based budgeting as required by the PFM Act of 2012. I must also add that this curriculum has been used widely, and at one instance I was invited to support another organizations to train a county as far as Elgeyo Marakwet. When I reached there, they gave me slides, and those slides were written HP Plus and the Kenya School of Government. So it was very exciting because I had carried mine, but when I went there, they told me this is the curriculum we are using. And that was not HP Plus, it was another one, I think, from UK, supported by UK. So this curriculum is very important, and this is an area also that we would also wish to roll out in more counties. I know we have not done much, but still there is room to ensure that this is the only way we can harmonize our planning processes within the counties by using one curriculum that has been developed. Kenya School of Government is a center of excellence for us in Kenya here to train government officers. So whatever comes up, I think it should almost be patented, such that even nobody else should be using it unless you're authorized by Kenya School of Government. But things have now gone out of, of the can. We cannot recall them back. So To that end, I think that was a very good output, having come up with a curriculum for planning in terms of budgeting, costing, program-based approach, and such. These are just some few examples from a rich bag of outcomes from our fruitful collaboration with USAID through HP Plus over the past 7 years. HP Plus has played an instrumental role in strengthening our healthcare system for the benefit of Kenyans. We also note that in the past 7 years, Kenya has mobilized increased levels of domestic resources through national and county budget allocation and increased savings through efficiency in planning and budget implementation. As a proportion of total government budget, Kenya is steadily moving towards achievement of the Abuja target, which now the current allocation is 5.5% of the total budget. And in 2013-14, it was 5.5%, and currently it starts at 11%. So you can see we are approaching the 15% of the Abuja declaration. Kenya's growing population and the transition in urgent health issues to non-communicable diseases, which are more expensive to manage, will continue to place a huge burden or demand on health services. Therefore, we must continue to expand the financial, human, and material resources that are available, while developing the capacity of the health system to achieve universal health coverage. The government is committed to improving the health sector to attain the country's goals as we approach the countdown to the 2030 development milestone. You remember also there is the issue of the innovation, the digital health that we are also moving towards, trying to ensure that all our facilities are connected, are digitized, and all our systems in the healthcare facilities. So these are also some of the areas that we also need to look at in terms of now the next step, in terms of how do we make use of telemedicine, issues of digital health, because some of the areas we have, for example, we all know that we have now the integrated molecular imaging center at KU Hospital. How do we make sure that we use such facilities, even to assist a patient in Mandera? You don't need to come to KU. How can we use digital health to ensure that the same medical officer at KU can be able to diagnose this person who is already in Mandera, making use of this digital technology? So these are some of the things that we want to come up with to ensure that we minimize costs of so much doing a lot of construction, but make sure that we use what we have and ensure that we use innovations to ensure that we can make minimum use of further resources, but we can achieve more results. So these are some of the things that are happening. The patient can just be diagnosed, and then the medical doctor can even be on the other side, look at whatever is presented, and we will be able to prescribe. Therefore, ladies and gentlemen, as USAID support through Health Policy Plus aids, and the project Whites Up and exists, we hope that the US government through USAID and other agencies will find a way to ensure that the initiative started can continue, to ensure that Kenya achieves strong healthcare systems, adequately funded and staffed with the right skills. We still have policy challenges that need to be addressed and for which we need support of our partners. I think this, I don't want to stress this further. It has already been mentioned. We need to institutionalize the ABC within our local institutions so that we build capacity. We also need to ensure that we implement health financing strategy and other documents that have been done through HP plus support. So I want to add there, and with those remarks, it is now my pleasure to officially open the HP Plus Head of Project Conference and to wish you all fruitful deliberations. Thank you very much.
Yeah, thank you very much, Director. We really appreciate that you are able to spare some time to grace this occasion. I think we've come from far. We've worked together in most of the activities that you have mentioned, and I'm sure you actually also appreciate the type of support we've provided. So, ladies and gentlemen, now that the conference is officially opened, allow me to shift gears so that we can move a bit faster, so that we can save some. So, I'm now coming in to basically present our program's approach and see how we normally implement the activities. And I have some few slides which I'll take you through. But before I do that, we have some assignment for you as well, because we don't want to take over everything. So my colleague Teresa will give you the assignment, and I hope that she will be able to. Please, can you explain the assignment?
Sure, David. Good morning, everyone. So, you know, in some of these meetings, we always want to have a bit of participation from all of you. And so one thing that we thought would be a great idea is to just have a quick Mentimeter poll, just to understand across the room. And as you can see on the screens, and for those of you on the tables, there's a printout. And with this Mentimeter poll, one thing we want to understand from you is, what do you think is the main challenge preventing Kenya from attaining universal health coverage? You know, Dr. Muga spoke around issues on ensuring that as Kenya we achieve UHC. But you know, there are certain obstacles and challenges that we tend to face. And so if you do have a phone that can scan a QR code, the QR code is up there. If not, you can always log into mentimeter.com and enter the code down there. So this is something that will be running throughout, and we'll be able to see the results a little bit later. So please join in. Let's see what majority of the team members think around UHC and the challenges around it. I think I'll stop there for now, and David, you can take over. Thank you.
Thank you. At least now we have some assignment for you. We'll be marking to see who has gotten it right, who has gotten it wrong. There will be a present for those who get it right, and also a present for those who get it wrong, so don't worry. So, I need to be assisted here. I think my slides on. Okay, there you are. So I have been given a very difficult task of summarizing the work of Health Policy Plus, which has been done in 7 years, and to summarize it in a few minutes. So you can imagine that difficult task. So I'm trying to remember my skills in primary school, where we were trying to do summary of a composition, so that you are able to see. So you bear with me if I leave something that you think I should have mentioned. So in terms of my presentation outline, I'll be looking at the health financing landscape. And this is important so that we understand where we are. And I will also go to what our program does in terms of the objectives of the program, and look at specifically the interventions which we do, especially at the national level, at the county level, and as you have seen our name there, HP Plus Kenya and East Africa. We are also in the region, because we understand that the problems that Kenya has are similar problems across the other East African countries. So we will briefly mention about HP Plus key results, and as I mentioned at the beginning, that is not our focus, because our focus is how we achieve those results. And then later on, my colleague will take us through some of the lessons learned in the course of doing this work, because those lessons are important for future projects and programs. So to give you some landscape analysis of our country, and this, for your information, I've just picked a few, because the literature is full of indicators that we can use to indicate our landscape. But today I just want to tell you that the government budget allocation to health increased from 7.6% in 2016-17 to the current, in 2020-2021, we stood at 11.1. We don't want to be the to say that we are the ones who made that happen, but you will surely find our contribution in the efforts that made that work to be realized. Again, going to the absolute indicators, because that was what we normally refer in theory as relative indicators. We can also look at the absolute indicators, the per capita health expenditure, which increased from $79 in 2015-2016 to about 106 in 2018-2019. This number is very important for those of us who are in this field, because it actually will tell you if a country will be able to offer the basic services to its citizens. And although there is no specific target or number, what the literature has shown is that if countries that have been able to achieve universal health coverage, as per the World Health Organization analysis, they were in 2015 around $86. So it shows that we were close to actually also attaining what the WHO says. And of course, the 106 has not been estimated in the $2012. So if we do that, we might be slightly just above that number. So that is important to note. We don't just celebrate by seeing 106, because that is the nominal figure, it's a current figure. But if we estimate that figure in $2012, then we are able to compare that number with the 79 that we have. The other thing which I need to mention so that we understand our landscape properly is the proportion of individuals insured, which has actually increased from 17% to about 20% in 2018. This is very important, again, because it now tells you whether we are attaining financial sustainability as we partake the services in healthcare. And countries, of course, like I've mentioned, there's no yardstick, but then we compare ourselves with those that have been able to attain universal health coverage. And so the relationship between insurance coverage and financial sustainability is universal, is in the reverse, because as you increase coverage, then financial sustainability also, security also improves. Then there's another important indicator which we'll look at is the issue of the opportunities to engage or to obtain services and also financing from the private sector. We look at this by looking at a survey to undertake, to show, for example, what is the proportion of people obtaining services through the private sector. And we can see that as of 2018, we were talking of about 34% of outpatient services obtaining services through the private sector. This actually indicates the potential that we have engaging the private sector, which has always been overlooked. Sometimes when we talk about healthcare public, we only refer to what the public provides, forgetting that there's a lot of potential that we can also get services through the private sector. Of course, with proper frameworks in place so that we get the best out of it. Then in 2018-2019, as we have mentioned, and my other speakers have mentioned, we supported the estimation of the national health accounts, which I think after we finalized, we are just waiting for the ministry to launch. And that's why these figures, we are the only ones actually presenting them here. They are not available for everybody at the moment because the document has not been launched. But what we have observed over that study is that we have seen government contribution increasing in the expenditure. This is an analysis of health expenditure from all sources. And we have seen that from 2015, when it was only 33% contribution from government, we now have 48% an increase. And you know, we talk about sustainability and domestic resource mobilization. If you want to focus on sustainability, we look at domestic sources. And here we are now showing that domestic sources are on the increase. And the other thing which is very clear from that chart is the contribution of donors. As you see, donors used to be about 22%, contributing 22%, but there's now a decline to about 19%. And what that shows us as government who are here is that the donor who has been supporting us is declining, is reducing the support. So what measures do we need to put in place to be able to provide services to our citizens? As I've mentioned, this you can write a whole PhD thesis on because there's so much information about financial indicators in healthcare. But let me only stop here for the purposes of giving you a synopsis of the financing indicators in the country. But now to come to our program, because our program functions around 4 objectives. The first one being support to the national government. As you saw, we have done quite some work with the national government. And these objectives also form the components of our work plan. We have the second component, which is the support to the county government. Those county government representatives who are here know the type of work we have done, and I will quickly just allude to a few of them, because I promised I will summarize. Then the third is the work we have done in the region, in the East African region, because I said that we have sort of common or similar problems. If you go to Uganda, they have high out-of-pocket expenditure. You will find they also have very low penetration in insurance coverage and so on. So we thought that we can support those initiatives that can actually have a common understanding and common approach to how we deal with these issues that affect all of us jointly. Then we also have some work we do which comes through what we call field support, where we utilize the capacities and opportunities that we have at the global, because we are a global project, we utilize those expertise and information to support the government of Kenya to use scarce family planning resources more efficiently, and I'll be giving you a few details about what we have done in that area. So before I go into the details of exactly how we have done this, because I promised the focus will be on the how, we want just to report a few milestones which we have observed throughout our journey as HP+, as we started sometime in April 2016. But a few months thereafter, we actually provided the critical information that informed the redesigning of Linda Mama. As you know, Linda Mama started by the Ministry of Health reimbursing facilities directly, but through the evidence we provided, the Linda Mama program was redesigned to be administered through the National Health Insurance Fund. All those were not just coming as spontaneous decisions, they were coming because of evidence that partners, including HP+, had provided to the government to be able to redesign Linda Mama. In 2017, the budget line item for HIV and family planning commodities was introduced. And this was important because we noticed that the government is relying on counterpart funding at the National Treasury. And anytime we have delays in procurement and so on, the Ministry of Health was almost helpless. So we thought that it's important, we proposed that we have a budget line to handle commodities at the ministry, so that if there are any shortages, the ministry can quickly know how to intervene. And of course, we have also supported Global Fund application processes through our expertise in costing, so that they understand how much each of those modules in the Global Fund are funded and how much resources they require. So we have participated in 2 rounds of Global Fund applications, and that is also on record. So countries also prepared counties also prepared their budgets using program-based budget. In 2018, we engaged with the Office of the Controller of Budgets, and we went round to actually support counties to be able to prepare their budgets in a format that was actually supposed to be the one that the government had recommended in the PFMA May of 2012. And so in 2018, we noticed that so many counties actually were able to provide their budgets in the PBB format. In 2019, the Division of National Malaria Program finalized their costed malaria strategy, and for the first time, they costed it, and therefore they were able to understand what the gaps are in each of the modules they were able to implement, which was a plus, because then they could utilize that as a mobilization tool. Because then if you are going to ask for more funds, you say, look, we have this much, and much we have can be able to cover this, and therefore the balance is what we are looking for. Very important information which will be attested to at some stage. Then, of course, the the national health accounts, as you have been told, was finalized, and this is very powerful information, which has actually in the past been utilized to inform policies in this country, especially the policies around abolition of user fees came as a result of this type of information, because you are able to see how much households are paying. And of course, you know the downsides of out-of-pocket spending. It's likely to lead to catastrophic expenditures and impoverish our people. So through the information we provided, user fees in the previous project was abolished, and so many other policies have actually centered around these tracking tools. The Kenya Health Financing Strategy has already been mentioned, which we have supported, and we've just come from supporting the dissemination to some of the regions, because we also noticed that it's not good to just write a policy and have it in the headquarters. We need all our people to know these policies. So allow me to just briefly go through each of the objectives so that you understand how we have been doing this. And the first objective, which I mentioned, is to support the national government, where the context is that we have witnessed declining donor funds, as I showed you in the previous landscape. And so the idea was to secure sustainable financing for universal health coverage, because that is now the in thing. Every country wants to provide universal health coverage, and so you need finances to be able to provide those services. So in terms of the interventions that we have, I'll just quickly go through some of them and then try to see what achievements we've realized based on those. We have supported development of policies for increased DRM. And under this, we have also promoted policies such as the Linda Mama, the Kenya Health Financing Strategy, the Coastal Malaria Strategy, and so on. And we have also promoted high-level dialogue in increasing DRM, domestic resource mobilization. We have noticed that when we engage with the ministry and so on, every unit used to work on their own. But we noticed that there is a critical unit called the Treasury, which actually are the owners of money. So you need to know how to communicate to the owners of money. So providing facilitation for such type of engagement has actually been part of what we have been supporting. And more critically, the evidence, because you can't engage without evidence. We have been able to support the national and county budget analysis iterations, and I know some of you have seen some of our reports. They are online. We have also been able to support the ministry to disseminate those reports. And they are very powerful information, because everywhere I go, people are talking of 11.1%. When you ask them, they will tell you, we got this from an analysis prepared by the USAID. But of course, our name is always there, HP+. We are the ones who actually supported that work, so we are proud about that. The National Health Accounts, as Director said, in fact, he personally participated in that process. So he is very clear and aware of what we supported through a lot of, because it requires a lot of resources and a lot of time collecting data and so on. And then not forgetting the activity-based costing and management. This is a powerful tool. For those who have not engaged with this report, we are finalizing it soon. It's actually for the first time we are going to understand the accurate and correct costs of providing services in Kenya. So that if you are in a county and you know how many people you are providing services, you can be able to quickly compute at the back of your envelope how much resources you require to be able to provide. So as a result of all these interventions, of course, we have observed different results. Some of them have already been mentioned. The budgetary allocation increasing from 7.6 in 2016 to 11% in 2020, 2021. We have also supported mobilization of resources through the Global Fund, as I mentioned, through our support in costing, as well as utilization of evidence. As my director put it here, evidence is not useful if you don't know how to use it. And so besides generating that evidence, we also go a step further to show our partners how we utilize the policy utility of that information. So that is very powerful, because we have information in the NCBA's National and County Budget Analysis, the National Health Accounts, which if you just open the page, you wouldn't know how that information is useful, unless you are guided through to see how to utilize that information for advocacy and also for decision making. Additional interventions which we have done at the national level include capacity strengthening. We've noticed that counties, as you know, the devolution was a big bang. It happened just like that. And so counties may not, some, not all, some may not have been ready to actually implement the PFMA Act of 2012. And so we had to come in to support. And I must say that through that support and the collaboration we had with the Kenya School of Government, now the PBB is a household name. And although we said that we have worked in a few counties, I remember we organized for a meeting for all chief officers across the country, where Dr. Shikeli is the chair, and we went through all these issues. So I think we have touched all counties. And then, of course, the issue of increased budget allocation, as we have seen, especially in the core programs of malaria, HIV, and reproductive health, we have supported that through the MTEF processes, supporting national government to effectively for the previous iteration was actually led by the Ministry of Health. We were actually in the background. They actually spearheaded it right from the word go. So we are now confident that they are able and ready to be able to undertake similar analysis going forward. Research institutions like the University of Nairobi, they were actually behind the data collection and part of the work that we are doing in the ABCM activity. And just to give you a snip, because we mentioned that these reports, some of them have not been launched, so we don't want to be accused of having disseminated a report that has not been launched. But just to ensure that we show you so that we create that appetite when it's launched for you to also read. We have provided here some chart to show you the major financiers of health in Kenya. This is information which is very important, especially for government, because sometimes when you go for meetings at the county or national level, the government will be sitting among themselves. But now you can see that when you sit among yourselves, you are only 50% of the services that are provided. So because you need to ask yourself, who else is providing these services? Who else is financing, so that you invite them on the table? And those are some of the policy utilities we have mentioned. We have utilized this information to be able to invite other stakeholders to come on the table. Then here is some extract from the national and county budget analysis. As my former previous speakers have mentioned, we have been tracking this and providing this report together, of course, with the government, to generate this report on an annual basis, so that you see exactly where we have come from and where we are headed. So as you can see, we are in 2020-2021 at 11.1. The target that was set in 2001 was to have governments allocate a minimum of 15%. And I'm glad Prof said he was there. So in 2001, that decision was made. We are in 2020-2021. We have not reached there. But at least we can show here that we are almost there, because we are at 11, and 15 minus 11, you are likely just to say it's 4. But to move by 1 percentage point, you've seen that it's not very easy. And you will see very clearly as we move on. These are information that we have in our reports, which we have published, and you have been told that we have a link where you can get this information and read for yourself in greater detail. And here is where now we want to ask, where did the money to fund core programs come from? Because the bigger picture may hide the nitty-gritties. So, but if you are in malaria, or you are in HIV, or you are in reproductive health, one question you should be asking yourself is that, where does your money come from? And this tells you, for example, for HIV, you are basically relying on donors. It's over 70%, or close to 70%. So if 70% of your money is coming from donors, who should be providing services? Is it the donor or you? Because you are having a small proportion. So then the donor who should be providing the free services, because they are the ones providing. That's the type of policy utility that we are talking about. You can utilize this to go to your leadership and say, look, we need to increase funding for this program, because if we have to to get ownership of our government program, then we have to increase domestic resources. Then allow me to quickly take you through our second objective, where we focus on support to the county governments. And the context, as I mentioned also earlier, is that there is overruns on donor funds, and we also need to secure sustainable financing support and also encourage that through local institutions. So just to mention that throughout our journey for the last about 6.5 years, we have worked in about 27 counties in different areas. But of course, I also mentioned here that there are certain interventions which we have done through the COG and through the Chief Officers Caucus, where we have actually touched all counties, including especially in the capacity building for UHC and other areas. And these counties are demarcated in such a way that there are those that we focus on support through HIV, there are those we focus on support through reproductive health and so on, and then others we support them because of malaria. And so like the PMI focus counties in the Nyanza and Western region come in through the support we have through malaria. Then, of course, we have private sector engagement. I know you may have seen one of our very powerful reports, which we did an analysis of how ready are individuals in our counties ready to pick up private sector interventions and pay for some services for convenience. And that is work in progress. We have generated the initial information that can inform further engagement. So in terms of the interventions, and here I'm just focusing on key interventions because of time, we have strengthened capacity on planning and budgeting using the PPB format at both in those focus counties and across all the counties using through the forums that we had with the COG. We have also supported evidence generation through the national and county budget analysis, because the national and county budget analysis, we have analyzed both the national MOH and the county budgets. We also have the county health accounts, just like we talked about the national health accounts. You can get that information also through the county health accounts, and we have those accounts for all the 26 counties where we were given the mandate to operate. And they are expensive endeavors, so we do not do them regularly, but at least for those that we have done, they have been able to inform policies a lot in those areas. And more recently, we did a public expenditure analysis and also took our staff partners in the counties on how to analyze IFMI's vote books so that you are able to understand where you are spending your money that you have allocated. And I think the counties of the PMI focus areas can attest to this. And the other work that we do is through advocacy for increased county allocation for health, and this is done through engagement. Like I mentioned, we've gone to counties where we've seen county departments of health have never been interacting with the county departments of treasury. And so through our intervention, we brought them together so that each one understands where the other one is coming from. And through that work, of course, we have seen adherence to Public Financial Management Act of 2012 by counties now preparing their budgets in PBB format. And we have also witnessed increased capacity on expenditure tracking to inform budget execution. Now counties know how much they are allocating to personnel emoluments as opposed to maybe other components, economic activities. Then the prioritization of health in county resources. You will see shortly that we have now moved from about 24 when we started in 2015 to about 29% in 2020, 2021 at the county level. This is an indication of how counties are now prioritizing health. And then we have also supported pieces of legislation. As Prof mentioned, we have a big challenge of ring-fencing funds that are collected in the counties. Funds are collected in facilities, but they are supposed to be posted at the CRF. And so to have those funds come back has been a challenge because there's no legal framework where counties have relied on goodwill and so on. So to ensure that we do that, we have supported counties here to actually come up with legislation to support ring fencing of resources that are generated. This is just to show you where we also have come from. Like I mentioned, in 2014, we were about 21.5, but in 2020, 2021, counties are now allocating about, on average, about 29%. Then our third objective, which is now focusing on our regional support, we support the East Africa Community member states to promote health insurance coverage because, like I mentioned, there is so much, we can't support everything, but we, through the collaboration and consultations we had, we agreed that we could cover some of the parts that affect all of us in general. And the context is that there is a regional platform now to promote sustainable financing and improved access to health services, which we now took advantage of and tried to capacity build them and also ensure that we support them to come up with tools that they can be able to utilize. And those are the countries we are talking about, we have been supporting. So in terms of some of the things we have done, we have finalized the EAC regional health policy, just so that we align it to all the countries. And we noticed this, that countries did not have a health policy. Just like we also didn't have at some stage, there are other countries that did not have. And those that had, we wanted to align it to the policies that exist in the different countries. We also supported regional dialogue on sustainable financing through expert working group. The countries came up with the expert working groups and we brought them together with their Department of Treasury to come up with proper ways of mobilizing funds across the countries of the East African region. We also conducted high-level advocacy for DRM with ministers, donors, and investors. When they had meetings, we supported them to actually be able to advocate for more resources for health because some countries were not allocating sufficient or adequate resources to support what they were promising the citizens. Then we also developed a resource tracking system that will then guide these countries to know how much resources they are allocating. Because we don't want one country, because if Kenya, for example, improves their healthcare system, Dr. Mbuji will tell you that the people from across the country in Uganda will be coming, and you see, you can't stop them. So we wanted to have a system that is more or less also able to accommodate all the countries, and a system that is similar so that we have more or less the same services. And we have, under this, we have seen regional approach to health through the EAC regional health policy. We have also implemented universal health and HIV coverage resource mobilization strategy action plan, because when the ministers met, they came up with an action plan. And a health financing resource tracking tool. Now, for the first time, all the countries are able to collect the same indicators, so we are able to compare and see which one is doing better than the other, and where we can be able to use that to see the areas of improvement. Our fourth objective, which is our other support to the government of Kenya to use scarce family planning resources using our field support funds. We have done this in the Family and Reproductive Health Division, and I have seen the representatives are here, where we have strengthened the county level enabling environment for family planning in Kenya, in some counties across the country, especially in Kilifi and in Baringo. We have, on the basis of this support, we have realized some 4.4 million allocated in the Nakuru budget of 2019-2020, which wasn't there before we went and intervened. So we have also supported Kilifi County to employ joint accountability, because we realize that with some other third party looking at how much you allocated and they are able to monitor, the counties are able to actually become accountable and allocate those funds to whatever activities that were earmarked. Through that, we have fostered accountability approach between County Department of Health and faith leaders. We actually involve the faith leaders, and we notice that the only way they can effectively engage is for them to understand the budgeting process. So we took them through the national and public budgeting process so that they understand and are able also to see and monitor the budget. We have also developed a curricula and training materials for strengthening joint accountability and enabling environment so that that information can be harmonized and utilized across all counties. So we started with a few counties together with the collaboration of our Department of Family Health. So soon you will be seeing that we have a unified curricula that can be applied across all counties. And then enhance self-reliance in family planning and county-led sustainability. This is meant to achieve commodity security for family planning commodities. So what strategies do we put in place to ensure that our commodity are secured over time for our people? And then we have also tried to come up with tools that can assist you know the efficiency of how you utilize funds within the reproductive health space, so that you can tell whether you are utilizing those funds efficiently or not. All those information that we have. So, like I mentioned, I don't want to focus on the results because the approach is, to me, more important than the result. Because if we continue with that approach, which I've explained, we can actually increase this. But just to mention to you that we have mobilized for ARVs and test kits in 2015, 2016 to 2021, 2022, $186 million. That is a huge number. If you were to divide by the number of people who require this, you can then ask yourself whether that money is adequate or not, and over all those number of years. Then, of course, for malaria, we mobilized in 2020, 2021, and 2021-22, $24 million. And there is also commitment for about $25 million for the same. And this is good because then we can build on what we have as a commitment. We have also done work in family planning commodities where 8.6 million was mobilized for 2021-22, and I must mention here that this is a department where we started working with them in 2021 in the middle of the pandemic, but they have been very receptive. Over time, we have been able to achieve remarkable results. This is some results at the county level, where I must mention that the 739 people whom we have trained, we know all of them. We know all of them, so we can also tell you where they are. Other partners, like our director told us about when he went to Elgeyo Marakwet, we are able to tell you whom we have trained there, and that's why you are able to get those slides there, because they were utilizing, and whenever we train, we are not selfish. We leave the material there so that it can be able to train others. And then, of course, we have worked in so many counties, including the fact that we have county budget analysis for all the 47. That analysis you saw is not just for the counties where we are mandated. And we haven't done this work alone. We have collaborated with many institutions. Some are represented here today, others may not be here, but I must mention that all the disease programs, malaria, HIV, and reproductive health, we have collaborated. We have also collaborated with the Kenya School of Government, as you are told, as well as the National Health and Insurance Fund. We have also collaborated in ensuring that those recommendations that we provided also found themselves in the recommendations that were sent through the Parliament for approval. The JICA, and I know they are represented here, we have collaborated with them in preparing the national health accounts. The WHO, the World Bank, and so many others, including our fellow IPs who are here. We have collaborated with PRB. We have collaborated with all the other sister organizations that are here from Palladium. And so if I've forgotten you, don't feel like I've left you out. I have so many, the slide could not accommodate all of you. And that is it. That is our journey, which I've summarized in a few minutes. You will bear with me because I was moving so fast. And if you need any information regarding all this data that we have it in your data product catalog. You can actually, at your time, read it through. And if you have any question, feel free to raise. We should be able to respond. So back to you, Teresa.
Okay. Thank you so much, Dr. Hoya, for that riveting presentation. Honestly, I think he deserves another clap because he did really well. Okay, thank you. So just because of time, we will go into a quick Q&A session. in case you have that burning question that you'd like to ask Dr. Hoya about the kind of work that HP Plus has done. So we'll probably take about 2 questions just because of time, but of course, after this, we are all available to have further discussions. So I'd like to open up the floor right now for any questions from any of the team members here. Oh, great, thank you.
Good morning, everyone. Thank you so much, Dr. Kahoya, for that very impressive, it talks about the journey that you have undertaken from 2016 up to now. And indeed, some of us have worked with you and we've seen the results that the project has been able to do for our country. So my question is around the issue of sustainability of data. And specifically, we've seen the progress that the country has made through your support in generation of evidence, in collection of health financing data. And that has enabled the advocacy efforts that have been undertaken and the results we've been seeing in terms of increase of domestic resources, coverage of in social protection and all that. But when it comes to sustainability, we know that we have a Kenya Health Information system in place that collects a lot of health outcomes data, and that really supports that element in the health. But now, but when it comes to health financing data, there is very limited amount of data in that system. So what has your work done in improving or linking that data on health financing to health outcomes data? So yeah, that's the question I have.
Okay, thank you very much, but I think you forgot to introduce yourself, maybe for the sake of everybody.
Oh yeah, thank you for that. I think I was very, very excited with the achievements. So my name is Deborah Ikonge. Currently I work at NASCOP, but before we worked together, especially in malaria programming with HP Plus. Thank you.
Thank you very much, Deborah. Probably I could drop for you one question from our online team. So I'd like to acknowledge that we do have participants online and they've been really engaging in some of their questions. So I'll just pose one question to you and then you can take those 2. So this question comes from Martha Kaugara. And it says that by HP Plus providing TA on DRM, we have observed the government's political commitment to the UHC agenda, including the pilot conducted in several counties. But in some of the counties, the process did not have much impact, despite the resources that went into it. So how differently could it have been implemented? So those are your 2 questions, Dr. Please feel free.
Okay. Thank you very much. As you know, I can't claim to be the only one with all the answers, so feel free to join me if you have answers, some of them especially on implementation of UHC. But allow me to respond to the question from Ms. Konge around data sustainability in terms of how we package this data and keep it. So there are 2 types of data here. There's data that we collect or we support collection as a project. That data, we have it available. It's available on request. We can always get that data so that you can utilize it, as long as we know who it is that is requesting and so on. But then you have mentioned a very critical point regarding the routine data collection that happens through the Kenya Health Information System, which really focuses on health outcome data and very little of health financing data or indicators. And that is a very important area. I know we've discussed this with Nguti before from the USAID, where we were trying to approach the Kenya National Bureau of Statistics so that we can also institutionalize and make that data collection a routine venture. And so that is work in progress. We have not reached there because, as you know, those who are collecting health outcome data are basically the technical people in their area. So we need also to support infrastructure and staff to be able also to know what type of data. And we had proposed just about a few indicators. For example, how much are people paying out of pocket? How much is the government or that unit or facility allocating to specific economic activities and so on? So that is work in progress. I know the USAID is having that as part of its agenda. And once it's made, it succeeds, you will be now also be able to access health financing data online the same way you access the malaria data on the Kenya Health Information System. But I know the government is here in case there are any other strategies. Like I said, for us as implementing partners, we may only know one side, but the government is a big umbrella. They know what else and what strategies are going on. If anybody is here and know what strategies are happening in the government, you are more than willing to support me in responding to that question. Yes, yes, Doc. Yeah.
He's insisting the government is here. I'm from the Ministry of Health. I saw him winking at me, so I thought he was, yeah. So anyway, so in terms of the data system, just to complement what he has said, we now have it in law, especially for the health financing aspect, that now our insurers, or especially the National Health Insurance Fund, will now be linked to all providers through a centralized data system. So that is now in law in the current NHIF Act. Currently also through the Ministry of Health, the Department of Health Information System is working to link all the facilities so that, again, once that they are linked through the EMRs, they can now report to the DHIS, which is a default reporting system, and also improving the indicators, especially for the systems, you know, not just financing, including HR and the other system where the data has been insufficient. We have very good data for service delivery, but in terms of the other systems, it's been very scanty. But the law now has tackled that, especially for the health financing. The other question was on the pilot. Yes, there was a pilot for UHC in 4 counties. That was Kisumu, because of the high prevalence of communicable conditions like HIV and malaria, but Prof has told us that malaria on that side is going down. Machakos because of the road traffic accidents, Isiolo because of the high maternal mortality ratio and sparse population, and Nyeri because of the NCDs. And the issue was to learn lessons. It was a pilot, to learn lessons to see how we scale up UHC. And the main priority then was to strengthen system, to prepare the system to cope, you know, as we enroll people into insurance. And the key lesson was that the input financing for UHC was not sustainable. So now the country is going to output financing through an insurance model. And I think we'll be speaking about that. So that's what happened. And right now we are on a roadmap to ensuring that everyone in Kenya is enrolled to a health insurance. Thank you.
Thank you very much. The government has responded now. I can't add.
All right. Thank you so much, Dr. Maina. And thank you so much, David, also for your responses. Okay, Dr. Okomo, it seems he has one more question, but I think that will be our last question. Karibu Daktari.
Yeah, thank you. Good morning, everyone. Yeah, my name is Dr. Okomo, Director of Health, Homa Bay. I want to thank HP Plus for the journey they've worked with us since 2016 in understanding program-based budgeting and, of course, health financing. You did talk about the correct cost of services in Kenya. I think this is a document everyone will envisage to have because it will help us understand with the populations that we have, how much do we need to put in health so that at least we can know the differences or the gaps. Whoever comes in, we know what gap we have. Thank you.
Thank you very much. We will make sure that we include all of you in our dissemination so that you see the type of work that we have done to come up with the accurate costs for the disease areas, especially in HIV, malaria, family health, as well as TB. That will be like phase one, but I know there are other phases which will now institutionalize data collection so that on a regular basis we are able to update any costs as we move on. So just keep watching our website. You will be able to see some information coming through in a few months. Thank you very much, and I think we can, yes?
Okay, thank you. Thank you so much, Dr. and thank you, Dr. Okomo. Always great to see you. I think it has been a very short Q&A session, but we've really gained a lot from what Dr. Maina and Dr. Hoya have said. But like I said, we are still all available to have discussions with you if you have any further questions around the work that HP Plus has done, how we've been able to implement, and some of the results that David has presented. So I think I will stop there for now, and you are all welcome to some tea, which is going to be served out here for about 15 minutes, and then we'll be able to come back in and get into a very interesting panel discussion. So thank you so much, everyone, for your attention, and you're very welcome to tea.
Have been lacking and which the HP has supported has been support on realistic budgeting.
We were so happy when we received the microscope, because now at least all patients with malaria can be tracked and treated well.
Before HP Plus, it was a blind, let me say, a blinded effort. People did not exactly know how much it cost, and so we just given money. HP Plus also has helped us analyze our budgets. This program-based budgeting, where is the money going to? How much is curative getting? How much is preventive getting? How much is general administration? Yes, unfortunately, most of our money goes to PE, personal emolument. Actually, over 60% of the amount goes to personal emolument. And development, of course, we look at the formula of having to get 30% going to development. So you are left with very little amount of money to do operation and maintenance component. And this is where the bulk of our service delivery is. We buy drugs using that money. We buy fuel, we buy food for the patients. So even an O&M of, let's say, 400 million, in just 1.5 quarters, it will be over.
5 years ago, I think our allocation was about 24, 23%. A lot of work has gone in, a lot of advocacy, a lot of capacity building. And right now we are doing an average of 28%.
For Busia, as now the county government has allowed us to execute 30% of its total budget. At least we are doing at around 30%, slightly above 2.5 billion, above 2 billion shillings.
Sometime last year, Development of the annual performance review was not there.
What we have been lacking and which the HP has supported has been support on realistic budgeting.
We were so happy when we received the microscope, because now at least all patients with malaria can be tracked and treated well.
Before HP Plus, it was a blind, let me say, a blinded effort. People did not exactly know how much it cost, and so we just given money. HP Plus also has helped us analyze our budgets. This program-based budgeting, where is the money going to? How much is curative getting? How much is preventive getting? How much is general administration? Yes, unfortunately, most of our money goes to PE, personal emolument. Actually, over 60% of the amount goes to personal emolument. And development, of course, you look at the formula of having to get 30% going to development. So you are left with very little amount of money to do operation and maintenance component. And this is where the bulk of our service delivery is. We buy drugs using that money. We buy fuel, we buy food for the patients. So even an O&M of, let's say, 400 million, in just 1.5 quarters, it will be over.
5 years ago, I think our allocation was about 23%. A lot of work has gone in, a lot of advocacy, a lot of capacity building, and right now we are doing an average of 28%.
For Busia, as of now, the county government has allowed us to execute 30% of its total budget. At least we are doing at around 30%, slightly above 2.5 billion, above 2 billion shillings.
Sometime last year, when we were having an engagement with the HP Plus, we managed to be taken through an analysis of the vote book and the standard chart of accounts. I'm happy even the malaria focal person, the county malaria focal person, after our meeting, he was able to go to the budget document. He secured his malaria funding and they were able to buy microscopes.
So you notice that the percentage of facilities that were doing microscopy were very few. So of the 3 million, we said we are not going to do anything else. We are going to do microscopy first, so that we have got 13 facilities that are not doing microscopy to start doing microscopy.
We were able to test or to capture patients who had malaria, Plasmodium malaria, and Plasmodium ovale. And so I think now the clinician could treat the correct thing. Because before they were missing it out, because MRDT cannot detect the 2 Plasmodium species. And also at the same time, with microscopy, we normally do quantification. So it is easier to detect a patient with severe malaria through quantification. And also you can do a follow-up by quantifying to assess whether this patient is responding to the drug that has been given or is not responding.
So that training opened our eyes. We've always been losing our money because we're not executing the budget the way it's supposed to. Actually, if you go to the accountant, he'll ask you, okay, fine, your money is there in the budget. How are you supposed to utilize it? How are you charging it? Which code are you going to use to charge this money?
If you looked at our budgets previously, we used to concentrate so much on the curative side. We could only look at how much do you allocate for drugs, how much do you allocate for buying of equipment. But thanks to their effort, we were able to see the need. We put these needs into the budget. We managed to generate evidence based on this particular intervention. And right now, if you look at our budget document, you'll find a lot of programmatic, a lot of support on preventive interventions, HIV, malaria, eye, RIMCA, non-communicable diseases, and many others.
CHP Plus also has helped us. Where is the
It's not there. The issue of development of the annual performance review was not there.
What we have been lacking and which the HP has supported has been support on realistic budgeting.
We were so happy when you see the microscope, because now at least all patients with malaria can be tracked and treated well.
Before HP Plus, it was a blind, a blinded effort. People did not exactly know how much it cost, and so we just give money. CHP Plus also has helped us analyze our budgets. It is program-based budgeting. Where is the money going to? How much is curative getting? How much is preventive getting? How much is general administration? Yes, unfortunately, most of our money goes to PE, personal emolument. Actually, over 60% of the amount goes to personal emolument. And development, of course, we look at the formula of having to get 30% going to development. So you are left with very little amount of money to do operation and maintenance component. And this is where the bulk of our service delivery is. We buy drugs using that money. We buy fuel, we buy food for the patients. So even an O&M of, let's say, 400 million, in just 1.5 quarters, it will be over.
5 years ago, I think our allocation was about 23%. A lot of work has gone in, a lot of advocacy, a lot of capacity building, and right now we are doing an average of 28%.
For Busia, as of now, the county government has allowed us to execute 30% of its total budget. At least we are doing at around 30%, slightly above 2.5 billion, above 2 billion shillings.
Sometime last year, when we were having an engagement with the HP Plus, we managed to be taken through an analysis of the vote book and the standard chart of accounts. I'm happy, even the malaria focal person, the county malaria focal person, after our meeting, he was able to go to the budget document. He secured his malaria funding and they were able to buy microscopes.
So we noticed that the percentage of facilities that were doing microscopy were very few. So of the 3 million, we said we are not going to do anything else. We are going to do microscopy first, so that we have got 13 facilities that are not doing microscopy to start doing microscopy.
We were able to test or to capture Plasmodium malariae and Plasmodium ovale. And so I think now the clinician could treat the correct thing. Because before they were missing it out, because MRDT cannot detect the two Plasmodium species. And also at the same time, with microscopy, we normally do quantification. So it is easier to detect a patient with severe malaria through quantification. And also you can do a follow-up by quantifying to assess whether this patient is responding to the drug that has been given or he's not responding.
So that training opened our eyes. We've always been losing our money because we're not executing the budget the way it's supposed to. After if you go to the accountant, he'll ask you, okay, fine, your money is there in the budget. How are you supposed to utilize it? How are you charging it? Which code are you going to use to charge this money?
If you looked at our budgets previously, we used to concentrate so much on the curative side. We could only look at How much do you allocate for drugs? How much do you allocate for buying of equipment? But thanks to their effort, we were able to see the need. We put these needs into the budget. We managed to generate evidence based on those particular interventions. And right now, if you look at our budget document, you'll find a lot of programmatic, a lot of support on preventive interventions: HIV, malaria, eye, RIMCA, non-communicable diseases, and many others.
HP Plus came in terms of assisting us as a department to review this act to make it legal for us to retain this money at the departmental level.
We negotiated for us to retain facility improvement fund.
The revenue that are collected from this, they generate, the Linda Mamas and everything, go to a specific account at the county level.
We cannot wait for the money to come back. Whatever we've collected, please, let's spend. People are dying. People need health services. And we realized it became an audit query, a very big audit query.
We have already implemented this. What we're just doing is legalizing the process.
That is a point when we decided to look for external partners who can help us in this area.
HP Plus came in terms of assisting us as a department to review this act to make it legal for us to retain this money at the departmental level.
To ensure that we have an elaborate provision that covers spending money at source, then the department will not have any audit queries.
HP Plus has played a key role in advocacy and legislation, and for us in health department, we have three key departments that we work with at the county assembly. We have the county health committee, we have the county assembly finance committee, and then we have the county assembly human resource committee. These key three departments have been working very closely with us whenever we are forming legislations or reviewing our legislation. One of them is the PFM Act 2012.
We know the PFM Act mandates all the on-source revenue to go through the CRF. Now, there was a big issue with the cash flows, and sometimes there's delay in facilities actually receiving money from Treasury. So we negotiated. There was a lot of goodwill also from the county for us to retain the facility improvement fund, and all through up to now we have actually been retaining the FIF.
The other year when COVID hit, this is when we saw the impact of this goodwill, because there's been that slow disbursement of funds from national government.
We had to redirect our funds from various accounts so that we are able to cater for the COVID expenses, purchase of oxygen. We had to do an emergency AIs, such things, in order for us to purchase oxygen, buy PPEs. We got support from the county, but there are some small things that we had to do for ourselves.
Previously, before the FIF budget, we used to have more of the push system, because the drugs used to be procured from that upper level, which is the county level, and we could get drugs that
were not, that we did not want at the time. HP Plus came in terms of assisting us as a department to review this act to make it legal for us to retain this money at the departmental level. And we had series of engagements with the various stakeholders just to have a look at what we had, what other counties had also put in place, and see if how we can come up with a legislation that will suit what Mombasa is currently doing to make it legal and avoid audit queries.
If there is no legislation, even UHC cannot work, because you must have a legislation before you implement it.
We decided with their consultants and HP Plus that instead of doing FIF, we will incorporate that FIF into a legislation, because we already have a Health Act that was passed. So we amend the Health Act to incorporate what we've all discussed in the FIF, so that when the Health Act amendment is passed, we will have achieved our goal.
We are relying on the current county assembly members to help us through the remaining phase of the process. HP Plus came in terms of assisting us as a department to review this act to make it legal for us to retain this money at the departmental level.
We negotiated for us to retain facility improvement fund.
The revenue that are collected from this, they generate, the Linda Mamas and everything, go to a specific account at the county level.
We cannot wait for the money to come back. Whatever we've collected, please let's spend. People are dying. People need health services. And we really need
in our facilities.
I have to appreciate the support for HP Plus. Surely I'm one of the person, 100% I understand their support from the inception period in 2015 to date. The HP Plus came in through advocacy. Apart from training, it came in for advocacy. One, they took for a meeting the county assembly team, headed by the county assembly health committee and the budget appropriation team. They were taken through. There was also a representative of civil society. So they were taken through. They understood why we need some more support for health sector.
After the program-based budgeting, that's when we were even aligned. You know, we knew there was a preventive administration and all that, but then under those three main programs, we didn't know which sub-program should fall under which. When we were presenting the first MPDSR report, that's where now the performance-based comes in. Because with the MPDSR reports, we are able to tell the MCS, these are the mothers who died.
It is divided.
Why did they die? because of access to a facility. Why lack of that access? There was no vehicle to refer that mother to that facility. You are there approving the budget. When you see an ambulance, you say, no, I wanted to see a physical health center because you will benefit from that. But you're not actually advocating for this ambulance.
Not for this. They are not news. They are made of second hand. High the salaries.
And prevent that untimely death. So when we were giving this report, the MPDSR report, they were like, this is the time you're now seeing the real facts.
Turkana is amongst the top 5 counties in the country which record the highest number of mothers lost due to pregnancy-related ailments.
Unajua kitambo tulikuwa tunalipa hospitali. Sasa nowadays mtu ukijifungua saizi mtoto wako pengine amegonjeka, hata kama ni ugonjwa gani unakuja tu unatibiwa bure. Kama sasa saizi maternity ukikuja, kitambo tulikuwa tunalipa vitanda na hizo nini zingine, lakini sasa nowadays ukikuja tu unafanywa kila kitu, unatibiwa na mtoto wako hivyo tu. Ukikuja hata mtoto ni mgonjwa wewe mwenyewe mpaka ile date yenye na expire.
Linda Mama has really been a blessing, especially in our poor community where the poverty index is well over 90%. Money generated through Linda Mama should be retained by the hospital so that the hospital can plow it back to improving services. Because I remember in Lorgume, in order to encourage most mothers to come and deliver in the hospital, we used to have to use Linda Mama money to buy something called Mama Pack. In this Mama Pack, we used to have, we could give a mama some basin, some soap, baby towel, a shuka for mama, a shuka for baba, a leso for mama. So all of them used to come to deliver in the hospital simply because they know after delivering they will benefit from that Mama Pack. Such an issue is not here.
Linda Mama iko sawa kabisa. Juu inanisaidia. Hakuna kitu yenye sipati. Kwa upande yangu na mtoto wangu.
The HP Plus Palladium Group, we really thank you so much. We are happy that you've shed light to us as Turkana a health team from the beginning of your inception period, 2015, to date.
His or hers. They already sanitized.
Good morning, ladies and gentlemen, again. Good morning. Yeah, we need to get started in the interest of time. And a warm welcome to this second half of today's workshop. And we're going to discuss on mobilizing domestic resources for sustainable healthcare financing in Kenya. And my name is Andrew Rory. I'll be the moderator for this session. For about 40 minutes or so. We have had a lot of discussion this morning, and all of us are aware of the changes we have undergone over the period 2010 up to now. And HP Plus came in handy in 2014-15 when actually we were getting to devolution, because remember 2013-14 is when actually the county governments came in. A lot of things have gone on in terms of domestic resource mobilization, and we have been able to link the resources to services as per the presentations that have been done. And one great achievement was bringing together the treasury, the county planning, and the health sector into one table. And that meant that they were able to reason and link together in whatever was being done. So this session is basically going to share experiences and get to understand how well we have done in supporting the national and county governments to mobilize the domestic resources for sustainable healthcare financing in the country. And for this discussion, we are glad to have a panel of experts from the institutions which have been involved in this process, from the Ministry of Health, the donors, the county department, and our implementing partner, the HP Plus. And they are supposed to share the trends, the insights, and the ideas. And more of it is actually to share the lessons learned so far, be able to give us a snapshot of the future outlook as we come to the end of this project financing. But as most speakers have said this morning, I think it's not an end. It's like a new way of looking at how do we start again and be able to accomplish and strengthen the various initiatives that have been impressed. So I have a panel of the discussants, and have with me Dr. Isabel Maina of the Ministry of Health. You can wave to the group so that those who don't. Thank you so much. Dr. Daniel Wanaina, Chief Officer Public Health, Services County Government of Nakuru. Dr. Wanaina, please, so that they can, yes, thank you so much. We have Mr. Nzoia Mungutu. He had already spoken to us, so he needs no further introduction. And also we have our partner, Dr. David Kawea, who has also been with us, the Country Director for HP Plus. Maybe to start us off, I would want each one of us, starting from Nzoia next to me, to comment on the results I've seen on the area exercise. If you can put it up, the Mentimeter, we had it earlier. There was an outcome from that exercise. If we can get it on, yes. Nzoia.
I think what is coming out from this question is that we have issues to do with funding, and two is the issue of out of pocket, and three is the public spending not delivering. Yeah, my response was number 3, but I think these are the issues that really threatening the financial sustainability of health services in the country, right from the demand side, where there are barriers, where we have high out-of-pocket expenditures, which impoverish people. They are sending people to poverty, and therefore, even if services are there from the supply side and they're not affordable, then obviously that's not sustainable. Two, there is the issue of the funding itself. Although I have a different opinion when we say that we have insufficient fund. I think in funding the sector, that is one. Two, but I think there is also the issue of, even with the resources that we are having currently, are we using those resources sufficiently? What are we buying with these resources, and how are we buying those resources? That's two. But overall, I think we need to have a two-pronged approach whereby we are addressing the issue of insufficiency in the sector, but at the same time also addressing the issue of the way we are using these resources, both technically, from a technical perspective, and also from allocative. Are we allocating these resources where there is need? That's targeted.
Okay.
So they are both issues to do with technical and allocative efficiencies that we need also to address. And I don't know whether the last
Okay,
one.
thank you. I know you wanted to go through all of them, but we can have Dr. Maina from the ministry perspective and the country perspective. What does that mean?
Okay, so thank you, moderator. First, I'll say that all the answers are right, as we were told by the examiner at the beginning. But just looking at number one is basically all those is what we want to address from the policy level. If you look at what is in the documents that you are all given on the financing strategy, the abridged version, that is what is there. We want to ensure that our financing is sustainable, that we have adequate financing, but we have seen the trend that it's been increasing at both the whole nation, including at the county level, what was presented earlier. But just as Nzoya has said, from the policy aspect is how efficient are we utilizing those resources. But again, you also need to address the issue of sustainability, and that's why probably in the talk we'll talk about transitioning and all that. So they're all right, including the red one.
Thank you so much. Now that you're saying it's about utilization of the resources, and we know health is heavily devolved in this country, Dr. Wainaina, I don't know what will be your take. Of course, you are not a pilot county, but now we have upscaled universal health care to all the 47 counties. What is your take on the outcome of the poll?
Thank you, moderator. My choice was number 2. In terms of families and individuals pay high out-of-pocket access as the biggest challenge. And the second one would be number 3. And I say that because, as one of the speakers said, the issue of funds insufficiency may depend on how efficient we are in utilization of those funds. And I think when you focus on number 2 and 3, then we are able to maybe even know exactly what we'll need in one so that we are able to plan better. Thank you.
Thank you so much. David, you're coming last, and you've been doing a lot of work in terms of the health in the country. As we look at the works you've been doing and the outcome of this poll, what do you see going forward for this coverage?
Yeah, thank you, Andrew. For me, first, I'm a Democrat, so I'll join the majority. But having said that, I think we need more money for more health. That is my first take, that we need more money so that we get more health. But once we have gotten more money, so we will also need more health for the money that we will have gotten. So that way, we end up achieving both increased resources as also and also spend them efficiently so that we get more health for the money that we will have been allocated. So that's my take. Thank you.
Thank you. And now picking up from more money for affordable health, I know the initiative we have been going through has been more of a multi-agency approach, and the work so far presented is commendable in terms of the counties which have been involved and the national government agencies which have been involved. And we know there's been a global kind of call towards ensuring sustainable financing for the health systems, specifically with the strategies for mobilizing the domestic resources leading to sustainability. And maybe I will go to USAID first. Don't say because you're next to me that you become the first one to go. But as the agency, you've been at the center of sustainability agenda. Of course, looking at the requirements for the health are quite big. So which global dynamics have actually influenced the agency's policy on sustainability?
Thank you, Chair. I think from where we sit at global level, there has been a number of dynamics that have influenced our policy agenda on a sustainable domestic financing of health services, and also for public programs that are heavily dependent on donor funding. One, overall, and I think it's across all particularly the lower middle income countries, I think we have observed a general decline in the overseas development assistance, ODA. I mean, that really has gone down, particularly those for financing programs of our interest, like, for example, the malaria, HIV, TB. We've seen that has really gone down. We have also, of course, Gavi is also another example. Global Fund, all those trends. I mean, we have seen declining trends in this. I mean, the challenge is, whereas this is happening, resources from domestic resources from these countries, like the government themselves, the internal revenues, and also from the private sector, they have not increased. I mean, to fill up some of the gaps left out by the decreases in donor support, and this really has informed our strategy on financing self-reliance because of the issues of sustainability threats. So moving forward, what we are envisaging in some of these countries, particularly those ones now who are joining the leagues of middle-income countries like Kenya, because of rebasing, and also because of they have attained epidemic control, and also the shifts in funding because of the emerging threats like COVID. That really calls for concerted efforts really to focus on sustainability of health and on these programs that are heavily dependent on donor funding. So that forms our basis really for engaging and pushing for self-reliance, where governments are supposed to take up more responsibilities in financing some of these heavily activities or programs that are heavily dependent on donors. Thank you.
Okay, thank you so much, Mr. Nzoia. And maybe picking up, you've talked about self-reliance and quite a number of reforms expected. And from the analysis of the presentations I've gone through, then it means that the Ministry of Health, more specifically, may require to do a number of assessment and basically come up with a reform agenda. And this reform agenda has to relate to an increased financing from the government to the health sector. And Dr. Maina, maybe what we may ask is that what will be the legal and policy framework the MOH has put in place to guide the realization of sufficient and sustainable funding for health sector in the country?
Okay, so thank you very much. Just to remind all of us in the room that we have, apologies. Just to remind all of us in the room that Kenya has a devolved system of governance. Now, the role of the national government, for example, the Ministry of Health, is to come up with policy standards and guidelines and capacity building and technical support to the counties, among others like referral facilities and all that. Now, in terms of moving forward, in terms of policy, it's about UHC, it's about sustainability, as Nzoia has said. So what do we have in place? We have the overall Constitution of Kenya that guides us, and it talks about the right to health. Now, to actualize that in the health sector, what the sector has done through the stewardship of the ministry and, of course, the county government is to put in place a policy framework. We have the Kenya Health Policy 2014-2030, whose overall theme is UHC. We have a UHC policy that was just launched in January this year, that talks about, in the health financing space, talks about equity, talks about efficiency, talks about adequacy in resource mobilization to ensure that we have, quality services for Kenyans. Then down, we have the health financing strategy. We all have it on our tables. And this financing strategy has various objectives, basically 3. One is to ensure that we have adequate resources. And whatever that means, we have various strategies to ensure that we have adequate resources. And we shall see as we speak along on what it says about domestic resource mobilization and the frameworks that the country has put in place to ensure that. Number 2, the financing strategy talks about efficiency in use of the resources and also ensuring equity in distribution of those resources. And then to ensure that we implement that, just recently, the government passed the NHIF Act. NHIF is the National Health Insurance Fund. Previously, it was National Hospital Insurance Fund. So from hospital to health, that means a lot, because NHIF was basically engaging hospitals. Now, when we talk of health, it means our insurer will be engaging all the providers, be it home-based care, be it the pharmacist and all that, all the providers that we can think of course, that are legally recognized by the government. So we have that, and what the Act says is that all Kenyans above 18 years must register with NHIF. We saw our insurance cover, what is it, 19.9, about 20%, about 17% of that is with NHIF, the other 2% is with the private sector. So to ensure that we increase that coverage and to ensure that we reduce that out of pocket that we saw, the 27%, 26 point something, is that all Kenyans must now belong to a health insurance. And number 2, for those Kenyans who will not be able to pay, because if you're above 18 and you're not working, the poor and the vulnerable, the government has set aside some money to ensure that they are paying for those who are poor and vulnerable. And for those in the counties, will bear me witness, actually they received money to support at least 1 million households this financial year, distributed pro rata based on the poverty index for all the counties. That's a way of ensuring that tax financing for health services. So that's one, including the other frameworks to protect that sort of funding. I just talked about the centralized data system. So the NHIF Act has many other frameworks to ensure that we are sustainable and all that. The framework also talks about matching funds, so that those in the formal sector, the employee will also match the contribution of, the employer will also match the contribution of the employee. That's one, and of course I've talked about the tax financing. The other framework that we have developed is a transition plan to a more sustainable financing. It's in draft form. We have developed that with COG, with the counties, and we are looking at finalizing that and also ensuring that the county level will also have some sort of county-specific transition plan. I think Prof, in his opening remarks, talked about the challenge that we've had about flow of funds to the health facilities. And we have tried to do, to approach it from the legal aspect, the PFM Act, But again, it become a bottleneck, because I say anytime you have two lawyers in the room, you have 5 different opinions for the same clause. So it becomes very hard to change the PFM Act. So what we've done is sort of do guidelines to guide the counties to sort of start, to sort of have their county-specific laws to ring-fence health financing or health financing at that level. And Prof said that his county is doing that. Some counties will also do that through processes, not necessarily through the legal framework. So that's one of the areas, and of course, other guidelines. We've had pronouncement about Linda Mama and others to ensure that there's more money to health. And many others that are in the document that all of us have. In the interest of time, I can see him.
Yeah, quite elaborate. I think you brought in all the things that you've been doing to support. And indeed, actually, as you put it from the start, that the national government sets the standards, the norms, and the policies. And then the core part of the health service, the health service delivery goes to the county governments. And maybe what we may want to hear from Dr. Wanaina, basically the county is where the work is being done. And the service delivery aspects and any standards we talk about actually has to do with the county government. So which interventions are you working for basically in the county to ensure you are able to increase and mobilize more resources for the provision of the services, now that service delivery is the core to the county governments? Thank you.
Thank you, Mr. Rory. I will really maybe be biased on what Nakuru is doing. It may not be representative of all the counties, but I'd like to share the Nakuru experience. Having said that, I want to confirm that 98% of the service delivery is actually at the county, or even more. And therefore, the focus should be at this level. For the counties, we have improved in terms of planning, and this has been largely supported by HP Plus and other partners. We have embraced program-based budgeting, and this has helped us to narrow down to every activity and cost it so that we are able to plan better. And out of that, we are able to come up with annual work plans. We have strategic plans that tie into the county integrated development plans that we implement. We've also had strengthening of the sector working groups for Nakuru County health sector, and I believe for other counties stands alone as a sector. And this has been supported, again, capacity building through KSG, and with a lot of support from HP+. And through that, we are able to advocate for more resources at the county level through engagement of the county assembly and the county treasury. And I'm very happy to say that most of the counties are now doing beyond 30% of the annual budget towards health. For Nakuru, again, we've been able to ring-fence all the resources that we collect in our level 4 and above facilities through FIF, a legal notice that was issued just after devolution. It may not be, it's not an act yet, but we've been able to rely on that and the goodwill and the political goodwill to retain all the monies collected in our health facilities, especially, as I said, in the level 4 and 5. We know there are many other revenues that come from other levels, like public health inspection, building inspections and such, which are huge, but that goes still to the county revenue fund. And to optimize on this, we have, among other things, increased the numbers of level 4 facilities in our county. And Nakuru is among the counties with the highest number at 16. At devolution, we had 7 hospitals. We now have 16. And this is, the approach is we take services closer to the people, we improve the services, but also ensure that these facilities are able to give that level of service so that we can also mobilize the resources from the people who come to these levels. We have also looked at level 2 and 3 in terms of NHIF claims, especially for Linda Mama, and with specific attention to ANC and PNC services that previously most of the counties and and previously we had not concentrated on that, and we realized that full ANC attendance and postnatal attendance is as good as a delivery in a health facility. So we find even dispensaries being able to attract refunds for these services from NHIF. Having said that, we're also looking at other programs supported by NHIF. For instance, you know that all high school students are covered under EduAfya. We also have now the indigents covered. For Nakuru, we have 48,000 households registered to benefit from this, and we have already started getting the capitation for this, and I think this is the way to go. The other thing I would like to talk about is that we are also exploring involvement of private insurance companies in our public hospitals. For instance, 5 of our level 4 facilities have engaged the TSC scheme to be able to benefit from or to leverage and to tap into that resource. Previously, all teachers, many of the people insured in private insurances prefer private facilities. But we have we've taken a bold step to improve our public facilities to compete with private facilities and draw from insurance, the private insurance, and we have started with the TSC scheme. This has been made possible, especially in places where we don't have very very good, if I may use that word, private facilities, like in our farthest areas of Kuresoi, in the north, where we don't have a private hospital. As I finish, we have also increased our efficiency in collection of this revenue through automation, and through automation of health services, both in terms of the health information and also in terms of going paperless and going cashless. We've been able to see our revenue grow from, in 2017, we were doing FIF of about 480 million. Last year, we did 1.2 billion shillings. I think I can stop there for now.
Thank you so much. A lot of interventions which have been employed to increase the DRM. I share the same experience as a school of government. We have worked together with USAID, HP+, the ministry, and the counties, and I can be able to relate with a number of these interventions. And listening to what the ministry, the national government has put on the table in terms of policy frameworks, listening on the initiatives from the county government, and I believe what has been shared by Nakuru may resonate with a number of counties maybe sitting in the house. They have had a good perspective, and I'm glad some things are coming up. I don't know whether they're realizable within the framework which exists currently, or the Ministry of Health needs to look at the frameworks to give county governments more leverage in whatever they want to do. But maybe for HP+, looking at the interventions you were there before and where we are now, how did the project come on to catalyze the interventions and realize the resource you have been able to share with us? Dr. Kawaya, please.
Thank you. And thank you very much, my previous speakers here. They have basically spoken to some of the things which we have supported in different counties. And our approach is three-pronged. We have been supporting in terms of capacity strengthening and mentorship. Because you realize, like I mentioned, we are a young democracy, and the devolution just came the other day, and it did not prepare everybody to know what is happening. Up to today, as we speak, there are some people who seem not to understand how devolution is supposed to operate. But so what we have done is to support in terms of capacity, even to be able to adhere to the PFM Act of 2012. It has a lot of guidelines, but we have realized that when we started working with some counties, they were not able to actually adhere with the PFM Act of 2012. So through capacity strengthening, mentorship, we were able to actually have most of the counties, and in 2018, actually, almost all counties were able to prepare their budgets in program-based budget format. Of course, we have supported the counties also in areas around planning and budgeting, especially to effectively participate in the medium-term expenditure framework, which is something which is very key, because that is the tool that actually now affords departments the resources that they are supposed to utilize during service delivery. The other approach we have used is to be able to support in evidence generation. because we have realized that resource allocation at the both national and county level is a political process, it's a negotiation. So you can't go to the negotiating table without the data, without the evidence that you require to be able to articulate your issues. So those who come, for example, from the education sector, they can easily say, we have this number of pupils, and for each pupil we need so much. So it's very easy for them to get whatever they want and they go. But for you who works in the health sector, what number do you go with? We don't know whether malaria will be there tomorrow, so you can't say tomorrow we will have so much malaria, so give me so much. So we need evidence that we should be able to now utilize to advocate for more. And so we have supported that evidence generation, and we have a lot of work we have done in public expenditure analysis, even just to show the money that was allocated in the previous year, how did we allocate it to the different service areas. I want to mention here that we've gone to some counties and realized that when you look at the budget, the way it's allocated across different service areas, you only see personnel up to the end. Then you start asking yourself, is health personnel, or is it medicine, or is it infrastructure, and so on, things like that. So having that evidence now, you can now start realizing what you need to do to actually reallocate your funds to be able to generate more health for the money. Then finally, our approach has been advocacy, as I mentioned at the beginning. And advocacy, we have focused in areas around even linking the departments of health and the Department of Treasury. Because we've, like I mentioned earlier, Treasury are the people who have the money. You are coming to ask for money to be able to provide service. Unless you are linked with these two people so that they understand each other, each one will be thinking that, why is this one asking for so much money? And yet we don't have malaria, you see? So you need to understand how do you link these people so that the finance person also understands why you are asking for a detergent. Maybe you need a detergent to do something. Then they are like, you see, we ask them to come to ask for money for health, then they want to buy detergents. So providing that advocacy platforms for them to be able to engage is basically one of our strategies we have applied. Thank you.
Thank you so much. Indeed, I think what you're getting from HP Plus is that they have had a number of interventions, technical assistance, capacity building, advocacy, evidence generation, and being able to be innovative enough to assist the various agencies articulate the agenda. And picking up from the discussion we've had, and we listened to the chief guest this morning, Macharia, talking of a number of initiatives which have been done. I want to turn to Dr. Maina, and maybe from the national level perspective, how has the Minister of Health strengthened capacity of the sector to advocate for more and increased domestic resources?
Okay, so thank you very much. First, I want to appreciate the comments from the last speaker, David. And I'm looking at my colleagues from the county, Dr. Shikeli, and just when they came to the room, this is off the cuff, they accused me of keeping more money than the county. Yet the work at the national level is just policy. So they were asking, how come the national level keeps all the money and the county government is where the action is? Well, we don't keep all the money. You saw the trends anyway. But I think David has talked about advocacy, and I really want to appreciate that we are working together as all stakeholders to ensure that all of us have the necessary capacity and skills to be able to negotiate with the Treasury. And I wish Treasury was here. Yes. But coming back home to the question, one of the issues is to disseminate all these policies, because the policies are as good if the people who are supposed to implement know them. For example, the health financing strategy, I think the previous speaker said last week they were in the Western Bloc disseminating to the Western counties. And very soon we'll go to the other regions in all the country, in the whole country, to ensure that they know the aspirations of the strategy, the role of each level of government, the national level, the role of the counties, for example, in mobilizing enough resources in terms of efficiency, in terms of allocation, in terms of negotiation, including with their oversight bodies, for example, the county assemblies and all, who allocate money at that level. The other aspect that we do is the sector engagement And especially with the county counterparts, we have what we call the Intergovernmental Forum, and with the partners and HP Plus, we've been able to reinvigorate the IGF, the Intergovernmental Forum, and what we call the Intergovernmental Forum technical committees, especially on healthcare financing. And I'm glad to see that Prof and the team here are members of that team, where we've actually been talking about the strategies to ensure sustainability, the strategies to ensure that money is linked to health, so that we have more health for money. At this point, we are actually not looking for more money for health. We are first looking at efficiency of what we have and ensuring that what is there reaches down to the health facility. So we've been working together through that engagement, the Intergovernmental Forum Technical Committees on Health Financing. Again, strengthening planning and budgeting, and I think the Director of Planning said that, through the planning unit, working with HP Plus and the other stakeholders, JICA and the team here, strengthening the program-based budgeting in the counties. But the work is not done yet, and we shall see. Capacity building of specific programs, I think that was presented. Advocacy, for example, in this era of UHC, we had to negotiate very much with Treasury. And even to get, for example, the 6 billion for the indigents, for the poor and vulnerable household for this financial year was because of negotiation. Because yes, you're saying insurance now it's mandatory. But how does the person who is very poor pay for that? So you have to negotiate with the person with the basket, who is Treasury. And we've worked together to ensure that we have the relevant data to be able to negotiate. And I think he talked about evidence generation. We have used the NHA and other data systems to ensure that we are negotiating and engaging the counties, including engaging additional grants and having conditions for, for example, when you give Linda Mama through the counties, the condition is that they ensure mothers are delivering in the health facilities, then you get more money, you build your system and all that, and many other conditional grants that exist, including MOUs with the counties and all that. But one key important one is, I mentioned earlier, is the Facility Improvement Fund guidelines, or guidelines to ensure that counties are able to ring-fence financing at that level, and we are looking at how to engage each and every county to ensure that they are doing that, especially at this time of transition. Thank you very much.
Thank you. Indeed, quite a lot has been done through a multi-agency approach. We listened to the Director of Planning, and of course also the Council of Governors, what has been going on, and the forums which were part of alluded to by Prof. Maybe going to the county and more specifically, maybe I can direct this to Dr. Wainaina. The capacity building has been a big issue which has been raised here, and the support which has gone into the counties. Then how has the departments of health in the county benefited from capacity strengthening in planning and budgeting, more specifically in terms of the resource mobilization? You can just briefly, very brief on it.
Thank you very much. Before I respond to that, I want to beg to be the devil's advocate. The national government has actually been supportive to the county governments. Actually, for Nakuru County, in the last 3 years, we've been able to mobilize close to 2 billion from the national treasury. So as much as we accuse them of retaining a lot of money, they are also able to finance strategic programs. For instance, the regional radiotherapy units that Nakuru, Mombasa, and Garissa have benefited from. In terms of benefiting from capacity building, especially from HP Plus, we've been able to, as I mentioned before, be in a better position to advocate for more resources, using our plans that we do on time, using the program-based budgeting that we have perfected over the years, and I'm happy that the moderator was actually the teacher for most of us on that subject. Then the other things that have come up as this capacity has been built, not just by HP Plus, but even other partners, where there have been requirements, for instance, for counter funding. For us to benefit from some funds. For instance, we have Nutrition International that required us to match what they are giving us, and they fund us directly. We have the Danida fund that is now decreasing, and we are supposed to allocate more, so that at the end of the day, in the long term, we take over some of these functions that have been funded by the donors. We've been able to, through the capacity building, identify gaps in our budgets and target mobilization to specific areas of interest, and helped us even lobby more, including roping in the public to engage the county assemblies during public participation to make sure that they prioritize health as it were. I think I want to stop there.
Okay, thank you. I think that's quite impressive, but the whole issue of sustainability was also discussed, and looking at where we have come from, Dr. Kawia, I know when we started in 2014-15, there were a number of issues we needed to put in place, and basically strengthening the capacity of the counties in planning and budgeting has gone a long way, and in terms of advocacy and what you're talking about. But the question I may want to ask is that from HP Plus perspective, what has been the most transformative change you have witnessed in the counties, and what other things are you willing to basically briefly just tell us is required? Because at the end of the day, it's about sustainability and being able to continue with this good work.
Yeah, thank you, moderator. I think you are right. One thing I normally focus on is that I define education as the ability to remember what you are taught. So if you train somebody and tomorrow they are able to utilize that knowledge to do what you train them, then you get satisfied that the training has worked. And that's what we have observed. Like I mentioned to you, if you look at the budgets coming from counties now, they are all in the program-based format, and that is important because of the benefits of PBB budgets. You are able to utilize or allocate funds based on specific programs and outcomes that you intend to get, and not allocating in terms of the budget lines and so on. And that's something we have observed across all counties. Of course, we have also had situations where we have witnessed county departments of health being very effective in budgeting processes, to the extent that other departments like agriculture and so on also rely on the people who come from departments of health to support them to prepare their budgets. And that is something we have witnessed in different counties, and they are here, they can attest to that. And the only challenge which I think we will be discussing later is attrition. Because today you have somebody who is very good, like Dr. Wainaina here, who understands everything about planning and budgeting, but tomorrow you go there, he's not there, and there is no mechanism to replace him and take over those functions. And that's what we are working on when we discuss with the Council of Governors to see how we can institutionalize the planning function in the county departments of health, so that it's not just about Dr. Wainaina, but it's about the function of the unit, so that it takes over the work of planning.
Thank you so much. And in the interest of time, maybe I want to bring in Mr. Nzoia here. And listening to what Dr. Sunita presented earlier, and what's happening in the world, there's some declining in terms of the support we are getting. And from your perspective, with the declining donor funding, what support do you see or you have in place for governments as you want to transition to this phase where we are talking about journey towards self-reliance, reducing donor funding? So which support do you see we look at from the donors?
Thank you, Chair. I think from where we sit, the discussions around transitioning have gained traction with the local systems, and we have the environment. I mean, there is the policy environment which has really facilitated this. Like, for example, Dr. Maina mentioned that the government has already adopted the health financing strategy, which guides the way we love to finance services in this country. There is also the issue of the UHC policy, which really provides guidelines on how that the policy is going to be implemented. And more importantly, there is a Vision 2030 still on the policy, and also there is the issue of the political will in this country. It's abundance, and both in terms of increasing the resource envelopes for health, and also from the demand side, also making services more equitable and affordable through risk pooling. I think so. The grounds are set; they are fertile, and based on the foregoing, the discussions that we've had, I think everything is pointing to 3 or 4 areas that we, from where I see it, we need to continue engaging with the governments, the opportunities. And one of the areas that we really need to focus on, to address the issue of inadequate domestic resource mobilization, is to really focus more on, engaging with the government to put more money to support health service delivery. Of course, we know that traditionally, and this is public knowledge, we know that most of the efforts around DRM has been focused on the treasury, raising more money from the treasury. But there is also the private sector, which has capacity, to both, contribute to financing, and also to provide market-based solutions. So that's one. 2, there is also the issue of, still on sustainability, promoting financial risk pooling mechanisms that target the poor, so that they're able to access services, quality services, without really having to pay. That's 2. There is the issue of efficiency and in the way we utilize the resources that we're having. So then moving forward, I think there's an opportunity to engage in health financing reforms. That's around the way we raise money, the way we pool and purchase, to increase efficiency and productivity. So that is also very key, because that is the only way we are going to achieve UHC. 3, and there's the issue of the debates around transitioning issues, donor funding going down, and government not, stepping up. So that is also an area that, we have to catalyze those engagements to ensure that the government really, and also private sector, take more responsibilities. And lastly, so there's the issue of
yeah, I wanted to say that because I know they would have to do a lot of asking for you, as much as you are saying we are coming to an end. But we have had this discussion when Council of Governors spoke. They said of unfinished business, which needs to be done. When I know my brother from Mandera spoke, he said that HP Plus has done a lot in some counties, but Mandela has not seen them. So there's need to scale up to other counties. When Prof spoke, he said a number of things have been done. They need now to be institutionalized. we need to get some new things being done. Maybe before you give that final part you wanted to say, I want to ask the Minister of Health, Dr. Isabel, given the position and you have heard all what is going on, and as we look towards further strengthening of the health systems, which are the priority areas and which can be your ask to the donor is here? So that I wind up, put your ask now.
My ask, donor, my ask is well documented on the abridged version of Kenya Health Financing Strategy, page 16 and 17. Well documented, but for the sake of those who are in this room, I will just highlight a few.
Yes.
That one, we have the strategy, we have the policies, we have the legal frameworks, but they are not yet out there. We just said, for example, the health financing strategy, we had a dissemination in the Western Bloc. We still have 47 counties to cover. And that is the technical team. We still have to reach my mother, who has to understand that she has to pay for her health insurance, and even make her, understand the reason behind paying for that. So it's reaching all the relevant stakeholders from the community, the leadership, the technical team who are in this room, the oversight authorities, COG, Regina here, and all the team. So it's, the whole team. For the UHC policy, for the financing strategy, for the legal framework, for example, the NHIF Act. That is one. Now, number two is strengthening the coordination mechanisms. I talked of intergovernmental forum. Ideally, we are supposed to, for example, to be meeting every quarterly. But then for the technical teams, they need to meet as often as possible, including every day, should the need arise. But then that means they need support. For example, if Prof has to move from Kisumu, or if Maina here has to go to where Prof is, you need logistical support for that. That is one. NHIF Act, it was passed. But then how do we communicate to Kenyans? How do we mobilize people to pay for insurance, for example? How do we ensure that the regulations for that act are known across board and the aspirations of that act are also implemented? I talked about the centralized database, which is now in the act. How do we ensure that we connect each of these facilities to be able to pick all this data that you are seeing here and to be able to make decisions, for example, for the next benefit package? How do we monitor the utilization of the package? So in short, I'm telling my donor here, we need to strengthen the M&E system, especially the M&E for the health financing, including the ICT platforms. How do we monitor the claims, for example? PFM. Let me finish for my donor. 1 more minute, because I'm the only lady in the group. So
okay.
Anyway, so PFM. So we've talked about the issues of the flow of fund. Unless we solve that aspect and work with each of the 47 counties, even if we mobilize all the resources in this world and they are not reaching the point of use, then we'll not have a change of the outcomes. We'll not see the outcomes that our colleague from Marsabit told us about maternal mortality. So that's a gray area that we need to work on. But for further details, page 16 and 17. Thank you.
Thank you so much. As we do the final, because I'm really cut off time, I know it's a good discussion. We will be able to listen. National government has spoken through Dr. Isabel. I believe you are still taking note, and I want to move to the final one. Because of time, I want to ask you, Dr. Wainaina, as part of your closing remarks, and only saying what you would like done, but just in less than a minute as we wind up, and that becomes our closing remark from Dr. Wainaina as we move to Dr. Kawe and back.
Thank you very much. I think for me, if I was to be asked, the program 3 of scaling up registration into national insurance schemes would be a priority, so that we are able to bring on board most of our people into a social insurance of some kind. Then domestic partners mapping would be very important as we look at sustainability. And for Nakuru, we've been able to do a bit of this and actually benefit from very huge projects from local partners who are non-traditional multinationals, including our religious organizations. And as we speak now, we are benefiting from a 300 million modern mother-baby hospital from a local church. Then the costing of health services, as my colleague from Homa Bay director talked about, it would be good for us to know exactly how we are going to cost our services, so we are able to tell how much we need at any point. And as I finish, we institutionalize this issue of the good practices and the good capacity building that we've had through strengthening directorates of administration and planning at the county level, so that we don't lose on the benefits that we've had from this project. And finally, national legislation. The national level is in charge of legislation and quality standards, and we should be supported as counties, not just to ring-fence whatever we are mobilizing, but also to have a policy framework to increase on that and efficiently use those resources and make health a national debate.
Thank you. Dr. Kaoya, 15 seconds. Your final remarks.
I will appeal for you to increase your resources by improving absorption. That is the only way you can actually earn money without asking anyone. Thank you.
Thank you so much. I know much has been said about what we need to do for the most outstanding work which has been done by HP Plus over the years. And we really feel that we need to continue with this engagement in terms of strengthening our health services in the country. And for the donor, Health Plus has already demonstrated what they have been able to do. We still believe there is much to be done. It's good to continue supporting somebody already we have seen deliver, and that's the message you want to put to you. So that is the request I've also put. So you can now use 30 seconds to be able to finalize.
So I mean, you see, when the donor, the DPHK consortium, I'm only representing USAID,
yes.
and I believe the same issues. I think that other donors, we should work together with the government to try to address this. So yes, we've had, but also I know in the room there are also other donors who we can collaborate with and provide TA to the government so that we can advance the issue of sustainable domestic financing. Thank you. So it's a clarion call to everyone, to all of us. Thank you.
Thank you so much, Nzoia. Thank you so much, Dr. Isabel. Thank you so much, Dr. Wainaina. Thank you so much, Dr. Kaoya. We have all heard about the discussions across the partners and the various agencies involved, and all of us in the room, if we had a chance, we could have shared. But the bottom line is that good work has been done. We don't need to stop. We need to continue engaging so that we realize more resources as we continue. This is a very heavy area. The sector of health is very demanding. The way Professor Muga said that where they started up to where they are, some things have not been realized, some things require effort. Thank you so much, and we wish you the rest of the session a very engaging moment. Thank you so much. Let's clap for our panelists. And I take this time as they exit to invite Paul and the other group of our panelists to wind up the session. We are running out of time, but try as much as possible to manage. Paul, welcome to the session. Plus our colleagues who are supposed to join us, please, you can cross over. Thank you.
So, good afternoon, everyone, and thank you very much, Rory and team, for that very rich panel discussion that has highlighted the space that our work as HP Plus occupies in the national conversation on health financing. You've heard both from the panel and from in the morning session when David was presenting, a very detailed account of the work that we've done, the collaborations we've had with the different partners. So in the next session is more of an open mic. It's sort of an open mic session where we hear from the key collaborators that we've worked with. Dr. Muga in the morning highlighted quite a number of counties are present in the room. And also we have representatives from the national government who are coming from the departments and agencies that we've worked with. So it's just an opportunity to work, to hear from these representatives who are present in the room. And starting off, without taking too much time, I would like to invite Dr. Bashir, maybe just within a few minutes, to give us an account of... yes, welcome. Yes.
Thank you, Paul. An
you.
account of Open Check. Is it afternoon or morning? Good afternoon, everybody. My name is Dr. Bashir Isak. I head the Department of Health. I'm happy to be here to have a lot of information that is very useful for the advocacy of health interventions and health expenditure. I've interacted with HP Plus at the department level from 2021. It was a very short, very stint, short stint, very targeted, focused with good results. I say this because we've identified a gap in our budgeting process and advocacy for family planning commodities. We have very many other needs, but we prioritize this because of global commitments with our development partners. Come 2026, as a government, we should be able to our FP commodities 100%. And this, we are on track because of the effort that we've put together with HP Plus. They have trained our officers and also for the whole directorate of preventive and promotive, because that's where we were missing the step. Most of the people were program people. They were just looking at the technical aspect, and they miss in participation of critical steps within the budget making process, and they had no clue on how to prepare and defend your agenda in the MTEF process, medium-term expenditure framework. And we've managed to get increase the budget line to above our commitment for this year. And we are hoping maybe before the 2026, we will be able to achieve that. Secondly, we have also engaged Treasury. We were talking to ourselves, but we just realized Treasury is slashing our budget because they have never come to understand where we're coming from. And we had engagements separate with them, and we have a CAB memo for the 5 commodities, strategic commodities. That's HIV/AIDS, TB, malaria, family planning, and nutrition. And we are very hopeful that the government is going to take up this because of the transition strategy and the plan that we have. In the next 2 years or 3 years, we should be talking about other things. In terms of, we had identified commodity security because that's a very, very critical. If there are no products, you can provide services. And if you are depending on a donor for your commodities, then you're at a very, very precarious situation. It's not that this is the only thing that we need, but where there's scarcity, there must be choice. And therefore, our choice now is to ensure that we have the commodities, first of all, secured from our budget, and then push for more. One thing I've realized in the presentation is that 70% of our programs are being supported by donors. That doesn't mean that government is not spending, but government is spending on the hardware, the human resource, the commodity security, the infrastructure, and many other things. If this software is not lubricated, those hardware are likely to depreciate and unlikely to perform. So our agenda now is to push in this current MTP, medium-term plan for the next 5 is we're trying to build a case for a flagship within the medium-term plan to have these strategic programs including the family health programs, funded directly by government. Even if we start with 20-30% of the software, we are good to go. Unfortunately, I've realized that within our flagships within the MTP for health is infrastructure laden. A lot of resources going to infrastructure, buildings and big hospitals, without actually looking at the needs of those infrastructure in terms of HR. In total, in terms of health system support, you have a very big hospital and you have not trained the required health workforce, specialized health workforce for that. It just becomes a structure that has locked doors, and there are many of them all around. We need those structures together with the other service delivery points. Investing $1 billion shillings in infrastructure or 2 billion shillings infrastructure, and 4 or 5 years down the line, you are not able to utilize, then that is a missed priority. So we need to move hand in hand. Whatever resources we put in infrastructure, we ensure that it delivers, or they deliver services and give us outcome in terms of the results. And second, thirdly, recently KNBS released some analysis of mortality and morbidity of the census 2019. It's unfortunate to note that the statistics are static as they are. Our mortalities in terms of maternal and child and infant have not changed. And we have started questioning, is it the modeling or is it that our investments are not yielding results? So as HP Plus, as you're exiting, the question that we have here is, are our investments linked with results? Is it inefficiencies within our system, which I know is there, or is it insufficient resource that comes number one? I know the answer that came here, all of them are right. We don't have enough, but the little we have we really utilized? Can we get results with what we have as we look for more? Asanteni sana.
Thank you very much, Dr. for that. And I think as Dr. Githuka comes on, just wanted to mention that Dr. Bashir, one of the things that he has highlighted is the increased government commitment to continue with the journey on sustainable financing for health, and through his department and collaboration, we worked with the DFH. The government has committed to increase family planning budget by like 38%. The next financial year's budget is going to have around 1.2 billion. And this is going to go a long way in addressing the issues of commodity security and the stockouts that we've witnessed in the past. So in the next speaker that we hear from is Dr. Githuka. Maybe you can take a few minutes and just give us the journey that HP Plus has worked with the division of the National Malaria Control Program. Welcome, Dr. Ari.
Thank you, and good afternoon to all. I'll just briefly be able to take us through the experience of the Division of National Malaria Program without necessarily repeating a lot that has been mentioned, that has cut across, and even my boss, Dr. Bashir, has highlighted. So I think I'll just focus on a few operational issues. We've really been discussing high-level, support that we've gotten in terms of resources and technical support. But as a malaria program, like has been highlighted before, through this current HP Plus project, we've undertaken 2 successful Global Fund grant applications. And the last one was particularly, unique, being that we had to do the whole exercise virtually for the first time. And I think one of the first country to do that, globally because of the COVID-19 pandemic. And the support that we are receiving from HP Plus was able to adjust to that, being able to provide us with an online support to have all these engagements done online, being able to support us with, technically, especially when it came to, the issue of, budgeting, costing, and prioritizing these grants. And the second one is also when it comes to, you know, mobilizing of resources from the government. We know that, and if Macharia was here and all our colleagues are here, that when you go into the MTEF process, it's actually very, very, you know, competing for a small basket of resources. And the programs like malaria, you know, HIV, TB are always viewed as, you know, heavily funded by donors, so justifying the need for additional resources, being able to demonstrate that these resources actually will go to priority areas that will have an impact is usually a challenge, you know, when you are seated in that whole big room where there are so many economists, there are so many other people competing for the same resources. And we have seen our envelope, especially beyond the counterpart financing, you know, grow from zero, what the ministry was allocating, to almost, you know, 800 million shillings. I was trying to convert it in dollars in my head. But so 900 million in this coming year. And we are seeing that being able to sustain. But, you know, like when we asked that question, you know, what is the reason why we are not able to achieve? Mine was that issue of the government allocated resources, you know, being unpredictable, inconsistent. If you drop the ball in the next year's MTEF meeting, then you'll find those resources have gone to someone else. So we really needed to keep that momentum. We really need to ensure that at each and every budgeting cycle, we are at the top of our game to be able to see that. And also, on the other end, be able to demonstrate the results with the funding that we have gotten. Because I said I want to repeat what else has been said, I'll just say also, HP Plus has supported us, you know, beyond that high strategic level. Whenever we have gaps within our program, they're able to see to that. A few examples, like we've said, having supported us in the end-term review for our previous strategy, costing our current Kenya malaria strategy, supporting us in doing the mid-term review of that strategy, and coming up with an updated, you know, strategy showing, you know, that will help us achieve our objectives by the year 2023. You know, things like supporting us to be able to revamp our website, having it up to date, being maintained so that it can be a place where anybody who requires any information about the Division of National Malaria Program, any data, you know, all these documents that you're talking about, the national health accounts, will be found hosted there and being kept up to date. We've also been able to have the G Suite workplace virtual platform that has also been supported by that, by the support through HP Plus. And recently, when we found that we had a gap, a big gap in our HIS tools, our monitoring tools, we've also been able to get support to be able to print those tools, because we know that, you know, there are gaps in the data that we are receiving will also have an impact in the output for the resources that we are putting in to be able to measure what their impact is as we increase resources from other partners. And as we speak, and as the project is coming to an end, we are just finalizing our malaria investment case that again will help us be able to, you know, provide more justification, provide a bigger and a more solid case for continuing to invest in malaria from all the partners, from the government, from the counties, and even the private sector that we haven't tapped a lot in. So as I finish, I would just wish to say that, you know, we are going to fill the gap of this project ending. Would have wished it would have transitioned to another one as we seamlessly, because even HP Plus used to support us doing our annual work plans, being able to track the performance of those work plans. I know we mentioned the other end of our challenges. We are able to get resources, but we are not able to utilize them. So we usually get that support. It's a place where we are going to, you know, fill the gap. And as I said, continuing to keep us, you know, updated within the government, which we know, and which is a good thing. There's usually a very, very high staff turnover. And the capacity that has been built within malaria program, and somebody goes and is reallocated to go somewhere else, we transfer that capacity there, we capacity build the people there, and they are able to benefit from that. You know, for example, like my colleague Deborah, who said previously she's worked under a malaria program, you know, a lot of capacity built on her on the issues of health economics, etc. She's able to transfer that to NASCOP and be able to support other areas. So that high staff turnover is usually good for us. is good for the entire ministry, but it also, creates that gap that we need to continually keeping on bringing the new staff that come into the programs, into the spaces that we work, up to speed to be able to maintain the momentum that has been there. So mine again is to appreciate, the support that we've gotten from the implementing partner HP Plus, USAID, and the teams both local, global, the way we've also worked together with counties to be able to see that our malaria response is having impact. As demonstrated by our declining prevalence, I think as Professor Muga said, the Homa Bay prevalence has, dropped to under 4% from as high as 38%, 10 years ago. And that is through all the partnerships that we have, and we hope that will continue. Thank you very much.
Thank you very much, Dr. for that.
So I would really appreciate HP Plus and the funders for this program for democratizing esoteric information to so many technical officers. And this, I'm not advocating for Kisumu only, but for other counties which have not benefited from this kind of information. Because previously we thought if misanalysis is so technical and only a cabal of officers in the treasury could actually access that information and analyze. And when we go back and we look at these officers, actually they were more analog than us. And then they came back and started consulting us on how to do IFMIS analysis. So this reversal of roles has really enabled the county departments, especially Kisumu, to realize the potential of planning, especially financial planning for service delivery. Thank you very much.
Very much, Dr. Tieno. I think you forget to mention that even Treasury comes to consult you now to help them with doing the analysis when they're generating the expenditure reports that are required. So the next speaker now, I would like to invite Dr. Salome Chelimo from Baringo. Dr. welcome. So, welcome.
Good afternoon, everyone. My name is Salome Chelimo from Baringo County. Today I feel so much excited and humbled to be part of this process and to be part of this close-out meeting, just to share some few experience from Baringo through the HP Plus program. I would like to register our appreciation to USAID through this project and also through the PRB project, that really we've seen a lot of immense support from them. And of course, it has translated to so many achievements. So just allow me to mention some few achievements and some processes that I feel it is actually good and encouraging. I know the previous speakers have spoken so much about HP Plus, which I think it also cuts across all the counties, but more specifically to Baringo, that Baringo is known to be a major, to have a major challenges, especially in accessibility to reproductive health services, which I think in the past it has been so much a challenge because of the diversity, because of the so many challenges, climatic challenges, poverty index being high and all that. But I want to mention today that at least HP Plus came in to support us and ensure that we have a defined program-based budget to RAMCA allocation. So it has actually changed some of our indicators. And I'm proud today that at least we did trainings and also ensure that we engage so much with the County Assembly and Treasury to ensure that we create budget allocation to these programs. And as mentioned by some of the speakers, that in counties in the past, like Baringo, we used to work in silos, as in the Department of Health, Department of Treasury, and also County Assembly has been working in silos, such that when you do the budgets, sometimes it's very difficult, and there's a lot of pull and push in terms of resource allocation. But we are proud today that at least the RAMCA and other primary health care programs and sub-programs have a defined budget. And of course, it has also increased because of the lobbying and also the consultative meetings that we've had among ourselves. So to me, I want to say, HP Plus, we are really proud of you. And we still need to do a lot of lobbying so that we increase our resources and funding towards those programs. Because as we speak now, funding to health care services is very limited, and we can't do a lot. But through that lobbying process, I think we can go far. Secondly, also, I want to say that HP Plus has also enabled us to do some strengthening in terms of capacity through training, that our technical teams have been able to go through the process of training to understand the budget process cycle, and also to understand how to do program-based budgets, so that it's actually have been a lot of work when our technical teams are not able to do that. But as we speak, I'm very much proud to say that at least all our technical teams from all the departments are now able to work through the process and able to do their program budget process. And I'm proud also to say that other departments like the agriculture, trade, and all other departments from the county are able to benchmark from Department of Health. I think that is a plus to us. They have also gone ahead and gave us their technical support in terms of ensuring that we have FIF and CHS bill or act, which is now an act of 2021. I think it's a plus because the process was very detailed, and they were able to come and ensure all the players actually understanding what it means to having an act, so that we ensure our facilities from level 2 to level 5 are actually financed through this act. Because it's a policy that ensures that everyone is involved and everyone gets the cake and the share of what we actually collect from our facilities. So to me, I want to say, HP Plus, we are really proud, and we are hoping that there is more and more that we need to do in terms of policies, in terms of ensuring that we cascade more policies from the national and also develop more policies in our counties. Finally, I want to say that HP Plus has also been instrumental in terms of collaborative and consultative approaches in budget process transparency. And I want to mention to this meeting that we are proud as Baringo County, because 2 weeks ago we received an award of budget process transparency, which means we were among, or we were the best county that were rewarded in the national. So through HP Plus, I think what they did, because we were mentioning about the process how we went through, and I think they did a lot of consultative through the budget process, through public participation, and some of the local partners and also the CSOs from the county went cascaded down to the sub-counties and even to the villages, and where whenever we do our budget, we also share and ensure that everyone understands. So we are really proud to say that Baringo, we are transparent, we are accountable, and I want to say that may you come to our county so that you benchmark also. So with that, I want to say thank you so much, and I wish our donors, you support the HP Plus so that they come, because I can see we can do more and more. You are yet to be there, we are not yet. Thank you so much.
Thank you very much, Salome, and thanks for that very compelling account from Baringo. And just as I invite the next speaker, what I wanted to mention is that in terms of HP Plus support, you know, Baringo is the youngest county among the counties we've worked with. We started working with them in 2020 at the height of COVID, and a lot of engagements were affected by the restrictions. But when we hit the ground, I think Salome has spoken to the results that we were able to achieve. And there's a lot of work that still needs to be done, but so far, so good. So in the next speaker, Dr. Mbuchi, maybe briefly from Busia. Daktari, karibu.
Thank you very much for giving me this opportunity to share my experience with after engaging with HP Plus. As you rightfully say, my name is Dr. Jane-Rose Mbuchi. I work for the county government of Busia, which is a diaspora county, because it's bordering Uganda. And I'm working as a capacity of the director of medical services in that county. But I want to tell people here I'm a doctor. And doctors and finances sometimes may not go together. I'm a gynecologist by training, and I still actively see mothers in that county. But as my capacity as a director of medical services, I'm supposed to know more than just treating patients. And when it comes to finances, I was very lay. You know, I was leaving this for the gurus of finances, the accountants, the planners, the economists. And we noticed that things are not going good with us because services are not being delivered because of budgetary allocation being low, first of all. And secondly, execution even of that budget was a challenge for Busia County. We got into the space when devolution set in 2013 as one of those unfortunate counties who didn't know, we're relying so much on national government to do everything for us. And so we got into that space without knowledge of even how much health costs for Busia County. So HP Plus came on board and helped us cost that function. In 2016, I think it was 6.7 billion to run health for the Busia County for 1 year. Now I think it should be more. With things going on, petrol going up, it might be going to, even 7 or 7.5 billion. For Busia County, which is having a population of about 1 million, slightly below 1 million. So I can imagine Bungoma, who's my neighbor, who have got more population. It could be much more than that. So we use this as a tool to advocate for more resources for the county. We began at around 20% allocation for health. Now I think we are just about 28, 29%. That was a plus because we are using that as a tool to show this is what we need for health and this is what you should give us. So that is one thing to allocate, to get more money. But how are we going to spend that money also? Somebody talk about efficiency here. Absorption rates. They're still very low for Busia, especially development. Docket is low. Why? Because we're not understanding whether these budgets that we are making and our activities are aligned. A good example was actually malaria program. We went advocating for money to be put for malaria program. Initially we had 9 million put in the budget. That one we utilized to buy some microscope because diagnosis was an issue for us. But we only spent a bit of it. The following year, we were given 5 million, zero expenditure. I think we didn't understand why, because we were saying we have 5 million for malaria program. Why are we not able to access this money? So HP Plus came on board again and gave us training on how to analyze and track using the FMI and the vote book, so that we're able to show these finance guys in Treasury, this 5 million is here. It's going to this vote. This is the code for it. And so when you go like that, you can reach the end and utilize that 5M. So 100% of that money was spent to buy very expensive microscopes to give to facilities to be able to diagnose malaria properly. But this financial year, we have another 3 million, which we were saying data capture tools for malaria is not available in our county, so we wanted to buy that. But mpaka sasa hivi, that process has not ended, and June is just around the corner. I was coming to this meeting and I went to ask the person involved, because that time our malaria coordinator, Dr. Nyango, was very forceful, as knowledge given to us by HP+, so he knew what he was talking about. But these guys of HMIS, I think were not in that training. So their money, the 3M is still there. So I'm like, what is the problem? Why can't you go and buy your data capture tools with these 3M that is in the budget? Oh, bureaucracy, procurement, that. So we still have, Nakuru is lucky to have a goodwill. That is so important right from tops. And so they're able to execute. As sometimes in Busia there, we do not have that goodwill, unfortunately. And we need to keep on going to Treasury. We are happy that you let us engage with them. But it's one department that is very difficult. Treasury, county treasuries, maybe even national treasury, they're very difficult. They wait for you not to spend your money. Then they'll just fix that money elsewhere. So one thing I think I'm so happy is that we are able to, if we take proactive actions, after just the budget has been passed, our program officers to start following that money, with the knowledge that they have, we can be able to improve absorption rates. I want to agree with David there saying, when the absorption is low, even those guys who allocate, the MCAs, they'll tell you, we gave you money last year. You didn't utilize it. What right do you have to ask for more money? So we need to iron out that bit of absorption, and I think to take the individual project officer to be going hand in hand, to remind Treasury, to show them how to utilize that money. Then it will improve on our services. And I think, as we're saying, we need to wish again for, where is the donor? The donor has disappeared. What I could wish, what I can wish for this program to be extended or given some more allocation, for them to come back and strengthen that system of implementing even sustainable ways of achieving this through, I know for Busia we passed an act to ring-fence the funds. Now we have an act in place. It even, the fund has it's called what? SPA, Special Purpose Account, at Treasury. So they swipe that money from CRF because they are telling us, you people don't know about finances. They are quoting for us that PFM Act 2012. And unfortunately for us, we have got very educated people, in quotes, saying that is what is the Bible. Even this act of yours, which you've passed in 2021, where there's conflict, we'll go for the bigger document. And they're saying, why do you want that money? It's unfortunate. So that's why I was asking Isabel, when I was not very happy when she said that when going the legal way, it was difficult, so they're just letting counties come with the legislation. It's difficult for us with even a legislation in place. So I think we should look at the conversation to change that PFM Act to just direct the funds to be ring-fenced, full stop. Because these people, they'll quote like you are saying, they'll interpret it. In fact, they're saying that 109, which gives counties opportunity to have their own legislation, the word may was used in B. So this may, and that is somebody in finance challenging you. So what do you do? That is the Bible they're quoting. So I think there's still room to go back to the table and have it made there in national and direct counties by changing that act from King version, St. James King version to something else, which now is going to help the funds. Otherwise, thank you very much, HP Plus. Welcome back. We are still going to welcome you back for another 6 years, 7, yeah, to engage with us. Asanteni sana.
Thanks a lot, Dr. Thank you very much, Dr. Ambuchi, for that. Now, I know we are pressed for time, but I still have 2 more counties that we really would like to hear from. We have Nyeri. Nyeri is one of the counties that we started with when we started the HPP this project, and they matured from our support. And Dr. Muriu is here. He reached out and told us, no, I have to speak. If I'm coming to your event, I have to give an account of. So, Daktari, karibu, welcome.
Yeah, thank you. Thank you very much, Paul. I know it's, as among the last speaker, it becomes difficult to say different things because most of the things have been said. But I think just like the speakers before me, I want to take this opportunity to thank HP Plus for this journey, because it's been a beautiful journey that we started in 2016. And so that I don't repeat things, I'm going to be very specific on some of the areas that we partnered in Nyeri and what were some of the successes. And just like some of my colleagues have said, is that on matters of program-based budget and on expenditure analysis, this was something that was reserved for a few. We didn't understand it as health managers. So one of the things that I really appreciate the support that we got from HP Plus is that we got a better understanding of program-based budget. And the most important thing is that there were follow-ups. Then when we did trainings, there were follow-up, that these trainings were cross-cutting at the county health management level all the way to the hospitals. I know part of the way forward was we were supposed to ensure that we cascade this to other levels, and I want to confirm that that process is ongoing. So I think, to me, I found that very unique, especially in terms of ensuring that these trainings were different. There was some bit of follow-up. But I think the one thing that I also really want to appreciate is on matters of advocacy. We had the opportunity, some of our officers were trained on advocacy. For a long time, this is a term that you used to hear, what is advocacy? And the fact that you're trained, as a health manager, someone who has not gone through some of these trainings, you don't know how do you ensure that you package the information right. So some of the skills that we gained in this journey is to ensure that we become better advocates. And this was done to senior management all the way from the county executive committee member and CHMT members. And I'll tell you, those skills have been very helpful. I've noticed some of our colleagues, they've said that they've developed a county level legislation in terms of ring fencing the health funds. And I want to confirm that in Nyeri we've been able to do that. But part of that journey is we've been able to use the skills that we gained. I can tell you it's difficult when you meet the members of the county assembly. Just having a round table, there's a lot of compromise, there's a lot of discussion before eventually you come to a decision. So some of the skills that we learned on advocacy, they were very key in terms of ensuring that we have that discussion. And I can say in Nyeri, we've actually implemented that legislation successfully because to date, it was enacted in 2021 in April. And we have seen our collections in hospitals triple during that period. Because remember now, there's more, people are more, the healthcare workers, they believe that this is their money, so they are willing to collect. So that has been very useful. I think the other bit, so that I don't repeat, the other bit that I would also want to say is that in this journey, HP Plus also supported us a lot in terms of resource mobilization. So we have also come up with, based on the what we learned with HP Plus, we've also come up with ways of resource mobilization. The other day, we actually applied for a grant, and we got it. We are among the 4 counties in the country that got that CDC grant. The other bit is at the county level, we've been able to start an amenity wing within just to ensure that we locally mobilize additional resources. So there's quite a bit of things that we've been able to do. So I think for me, in brief, I would say that we really appreciate the support that we've gotten from HP Plus. And I want to challenge the vice chair of the caucus that let's ensure that the whole bit about ring fencing health fund is cross-cutting, because it's been a game changer in the county health system, especially in the devolved health system, and the advocacy. Those are skills that I believe they need, not just for a few, but they are skills, especially at the health management level, all of us we need to have. So I think with that, for me, once again, I really to appreciate the support that we've gotten in this journey, and hope that we get a renewed project so that we can be able to do more than just we've done. Thank you very much.
Thank you very much, Dr. Thanks for that account. Now, on the next speaker that I would like to invite is Dr. Shkeli from Mombasa. And Mombasa is one of the counties that we've really worked with. And like Nyeri, we dropped off at some point, Mombasa has always been there through and through up to now. So Daktari, please welcome Dr. Shkeli.
Asante sana.
And tell them that your county is the most beautiful one in this country. We invite our visitors to come and see.
Karibuni Mombasa.
Yes.
You know, they say Mombasa Raha is you. Yeah. So asante sana, thank you very much for this invitation. And as you rightly said, HP Plus has been with us from the start of devolution. When PFM Act in 2012, it actually required that the budgets be done in the program-based budgeting format. And HP Plus, through its courtesy of HP Plus, they went through the formatting processes with Council of Governors, and Mombasa was part of that. The first department in the 11 departments in County of Mombasa to do program-based budgeting is the Department of Health. And everybody wanted to learn. In fact, they would come, my fellow chief officers would say, take us with you. You know, when you go for training, please take us with you. And when we talked with HP Plus, said, no, this is only for health. But so right now in Mombasa, we have 20 TOTs on program-based budgeting. And for us, we did not just, and we actually, HP Plus institutionalized the program-based budgeting process. We now do also the sector working groups. And through that, we have actually, we work together with the county assembly and the county treasury. Yes, I know they are very difficult, but I think when you do the processes with them, they become a bit more softer, yes. Not the best, but softer. So we have the director of planning, economic planning, who is with us, and the director of finance, or the finance officer from treasury. And then we have two chairmen from the county assembly, the chairman of health committee and the chairman of budget and finance committee from the county assembly. It's very, very important. And for the legal, when we were doing our regulations and of course the act, we actually also brought in the team from the legal and justice committee from county assembly. It's very, very important that we bring them on board. And thank you very much, HP Plus, for actually assisting us on advocacy and lobbying through the county assemblies. And with that, we have actually seen the fruits. From 2015, 2016, the budget for Mombasa County was actually 2.7 billion. For this current year, we have gone up to 3.7 billion, a billion more. Mombasa also has done a lot of analysis. We have done our county health accounts and also expenditure reports. And from the expenditure reports, we actually found that most of the monies or the expenditures was actually in outpatients. It was really shocking, not inpatient. We always think it's inpatients, they spend a lot, but actually it is outpatient. And when we did a deep dive with HP Plus. So we dived deeper and we found that it was actually pharmaceuticals. All the monies in outpatient was actually in pharmaceuticals. And that's where the out-of-pocket was coming from. So we worked on it, and we actually reduced out-of-pocket from 30% to 20%. And I think to sustain the gains, we also said, of course, as you're saying, Madaktari, we don't know finance and we don't know these things. One of the things that HP Plus really did great for us is actually getting us an economist. They helped us to employ an economist. They were ready to give us an economist, but unfortunately the time lapsed and the procurement process took too long. We've had 2 economists, and I'm happy to say that right now we have our own homegrown economist, health economist, who went to study and is back. In fact, he just came back about 3-4 months back, and we've taken him to the planning department, economic planning, to go there for on-job training, so that when he comes back, he's ours. But we will not leave the treasury, guys. We are still with them. So I think we've done a lot. In fact, when we took the county health accounts documents and the expenditure reports to His Excellency the Governor and to finance the waziris and all, they were so shocked. They said, what is this, you know? They always see the national health accounts. They've never seen the county health accounts. So it was something really great, and we were really praised for it. Of course, courtesy of HP Plus. Thank you very much. We have our FIF regulations, Dr. Maina, which are ready. They are actually at the final stage at County Assembly, and they're almost done. I cannot sit down and not really appreciate a number of people. I've seen HP Plus from HP Policy all the way. I would want to tell you, Dr. Sharma, that Kenya has some excellent experts and consultants, and we've worked with them. I was the head of the hospital and then became director, provincial director. I've gone through and I've seen them. And some of them are Dr. Wasuna Owino, I think he's worked here, Madam Angelina Saparo, Mr. Stephen Mushiri. Mushiri's gone. Is he? Yeah. In fact, Mr. Mushiri, I would like to say when you were the head of HPP, is when you took I was the chairman of Chief Officers of Health, and I actually called him and said, you know, there are only 12 counties which are under HP Plus, and we are 47 counties. Nobody, you know, when we had the meeting, they were saying, what is program-based budgeting? So when I spoke to Mr. Mushiri, he said, yes, we can do it. And he gave us actually 5 days in Windsor. Yes, to Windsor. Yes, Dr. David was also there. So we were taken to Windsor, and when we left there, I think all 47 of us now, and that's when the program-based budgeting really started. But before that, it was only 12 counties that actually knew how to do it. So on behalf of all the 47 county chief officers of health, I want to say thank you to HP Plus, and also not to forget the senior economist, Teresia, and our finance officer, Paul, who have always been with us. The whole team is great. Dr. David, you are also you've been a consultant all through, and now as the head. And Regina as well was head for us for a short time, and excellent. So I'm just saying that Kenya has these great consultants, experts, that really have done a great, great job. We just wish that we can continue again. The journey has not ended, and we really pray that, so our appreciation from Mombasa and from 47 counties is actually to HP Plus Kenya, HP Plus Global, USAID is not here, in absentia. Oh, sorry, okay, sorry. Okay, so USAID, but you know, I was told once to say USAID funded HP Plus, you know, that's the way it is. But thank you so much, and God bless, and PEFA as well. We'd really, truly appreciate. We would not have been this far without this funding. I think Kenya still needs, or health really needs funding. I know there's the journey to self-sustainability, but we should take us there slowly. I don't think we are ready. Yes, Maina, I think you know, she's smiling. Yeah, progressive, yeah, slowly, but we will get there, sustainability, but we still need a lot of funding still and support. Thank you so much.
Thank you. Thank you very much, Dr. Shikeli. Thanks a lot for bringing that session of the speakers to an end. And as we end this session, I just wanted to maybe give a few remarks that all the accounts that we've had from the counties, we have like more than 13 counties here. And each one has a unique story, unique achievement on what HP Plus has done. Our collaboration with them has highlighted. Even at the national level, there are a number of agencies that are not present here. I'm happy Andrew Rory is here, and he has spoken to the work that we did with the curriculum and the trainings on PBB. Most of that work has focused on the budget process, ensuring that the budgets are done according to the legal requirements. But the next phase of the work now, as Dr. Inaina and Dr. Muga mentioned, is now to focus on ensuring efficiencies in terms of budget implementation. So one of the economists, I think one of the Nobel economists said that, you know, an economist is a plumber. Here I want to say that the PFM system is the plumbing that underpins sustainable health financing. So without addressing the inefficiencies that underpin the PFM practices at the counties, we are going to face more of the challenges that Dr. Muga highlighted in the morning. So that section of the addressing the underlying inefficiencies need to come out and needs to be addressed in the next journey of health financing. And then as I also move gears, there's a speaker I really wanted to bring on board. We are not just about PBB financing and all. There is also work that we've done with the community. And I just wanted to, Mustafa, just maybe you can just wave. I know we are time-bound, time-bad, but you could just wave. Mustafa is from a CSO that we worked with in Kilifi. And what we did is a joint accountability. We worked with them on expanding, bringing more voices of the youth into the policy discussion and the decisions that counties make. And the work that we did culminated into a very strong engagement with the interfaith leaders in Kilifi, and we addressed some of the issues around family planning and financing for family planning and uptake for family planning. There's a video to that effect that I hope that you can be able to see as we take a break for lunch. So without much further ado, I would like to take back the program to Mr. Rory. I think the next session we are going to listen to a summary of the lessons learned. So I'll give the mic back to Ms. Robinson. Yes, okay, thank you. All right.
Good afternoon, everyone. It's always difficult to be the last speaker. Did I hear that somewhere? Thank you, and I think these are more or less, I don't see what I'll say that has not been said here, because all the lessons that we would learn has been mentioned in this session, but perhaps we could look at a few that we have learned over the process ever since HPP and HP Plus. We have known that leveraging on bilateral relations and collaborations are quite important, and I mean bilateral in such that we have to work very closely with your bilateral partner, and in our case, working closely with USAID, looking for support whenever we have challenges, and when we are trying to reach out to our clients, our beneficiaries like the ministries and the counties, we have benefited from that support very much, and it's something we know that is, if we resurrect, we shall be strengthened that. Then at national and county level collaboration is important to utilize comparative advantages and synergies during implementation. We have worked with other USAID partners, including MCGL, others who've expired like Afya Uzazi. We've worked very well, people like PACE, World Bank. We did a study together, JICA on KHFS and SHIF. And then the other lesson we have learned in terms of working is importance of co-creation and designing activities. For example, what has just been mentioned here, when we engaged with DFH, we sat down together and we worked a program which both of us were implementing. So it goes into their work plan, AWP, and also comes into our plan. So that way ensures that implementation will be smooth. And that one we also did with Nakuru and Nyeri during the time when we were working together. And then this issue about capacity building, I think we've had it severally. Even though we worked together well with the KSG in building the initial capacities and mentoring, and I think it's important to continue mentorship so that the skills are properly built, and to include a critical pool of people. We will continue doing so. Just we've heard from Dr. Shikeri about now ability to keep internal health economists to do the job. That kind of thing gives sustainability. We have done many other things, and we have also learned the value of that co-creation. We've worked on with the NAC at the University of Nairobi on the ABCM work, activity-based costing work, where that collaboration has built in the skills. Now, I think it will be less difficult to implement such a thing in future. And then a lot of things have been said about evidence. And this one, just to summarize, is just to say, if evidence is there, like David said, and understood, it will be used. We have tried, even if the evidence is there, please, we have learned that engage with the people whom you want them to use that evidence. Go to platforms, including the chief officers meeting in Windsor. Go to meet the CECs during their meeting in Naivasha. Demonstrate the evidence and how it can be used. And then you'll be hearing it being mentioned everywhere on many other platforms. I don't know if I have to say about future outlook. I'm saying as who? What do you think we should do looking forward? Start with page 16 and 17. So I need not say support KHFS and UHC policy implementation because a lot has been said about it. Even the one about strengthening the stakeholder engagement platforms, including implementation of partnership framework, HSIGF, HFICC, COG technical capacities to focus, including things like FIF bills. These are still places where there are gaps here and there. And perhaps for those who would be thinking about what area to support, kindly look at that. We've had a case, we have about tapping of private sector resources. I had done that slide. We had done this slide as HP Plus before Dr. Wainaina said that they are already tapping private health insurers to come and fund, to pay also for beneficiaries in their hospital, which are these opportunities in the private sector which you could tap more resources. Then also, I think it came out very clearly that supporting research and evidence is quite important. We have heard about ABC and costing. We hear costing, and David, I think the challenge about every country wanting support to costing is something that partners and donors and everybody should try to see whether it's a good area. Then something I promised Mr. Rory, having been my collaborator since HP Plus, is that innovation also. Look at opportunities for innovation. For once, even when there was COVID, and I think, Rory, you forgot, we redesigned the PBB program for online delivery. So also look at that, where innovations can come to make more efficiency delivery of support. And I hope you'll institutionalize it as you institutionalized the main PBB program within KSG training processes. Then we've heard a lot about peer-to-peer learning and engagement, inter and intra-counties. I want to tell Nyeri your first draft of the FIF when it was cost. I've chaired this secretary with many other counties because I was private to it. So that kind of sharing is something which possibly future outlook is to promote how it can happen, the best practices happening there. You have shared, I think Nakuru has shared a lot of things with other counties. That's one area. And then we still find some gaps within PBB, AWP, and IFMIS linkages, which can be filled up. there are still some countries which have really done these linkages, have been doing quite well in planning, in budget.
Also, in collaborating with other partners who are looped in when preparing the AWP and sort of harnessing all the resources within the health sector. And I think these are the few areas. I think we have mentioned many other areas that we can add on to this slide in the final workshop report. That's all for now. Thank you. Back to the master of ceremony.
Thank you so much, Robinson, for that brief on the outlook and the way forward. Indeed, there's a number of things. Some of them will be picked up from the speeches we had this morning, the deliberation we had in the panel, and the presentations from the various member institutions which have participated in the program. And we will say that ours is just to document and see how we can upscale that. Of course, the challenge you have put to us, it's true we converted part of the materials to the e-learning platform, and we look forward to continuing providing those materials through that platform, not only to USAID and also to other partners. This time I want to invite Dr. David to take us through the closing remarks for the day. Thank you so much.
Yeah. Thank you very much. I think we've gone over the hour by a few minutes. Our apologies. We intended to be done by 1 o'clock so that we could have lunch for 1 hour or so before we depart. I know that the discussions have been very exciting, and I know there are very many people in the audience whom we really wanted you to speak. But due to constraints, because of time, we may not all be able to speak. I know my Palladium country director is here. I wanted to give her a chance to speak, but I'm sorry, time cannot allow. And many more members from our counties. We have some videos for those of us who may have been coming from other counties like Turkana. I know you never got a chance to speak, but you know we had a video with you. So we will have that video also on our online platform, so that anybody who wants to listen to what we've done in Turkana can also have to listen to those videos. But saying that, I want to just take this time to thank all of you for having spared your time to come and attend this important event to us. This event, as you know, is very emotional. Some of us have worked with you very closely for many, many years, and now we have to say goodbye so that we exit the stage, so that we transition to something else, or maybe some other person comes on the stage. So we have guests from the national government, from the county governments who have been here. We also thank our key speakers who are on this table to ensure that ensure that they attend the meeting. I know some of them have already left, but it's because they asked for permission to leave. They had other engagements. Of course, we don't want to forget our donors, represented by Wairimu here, who is here all the time with us. We really appreciate that you have been able to stay all along. And before I close, I just want to ask the people who are behind the results that we have been seeing here to just stand up wherever you are, so that we appreciate you. Unfortunately, we didn't have time for all of you to speak. HP Plus staff, please stand up. Yeah. Just to mention that those are the current staff working with HP Plus, but we have other staff whom we have worked with before. I can see you there. Please stand up. And Mr. Mushiri, please stand up. I know the others have left, but we really appreciate, because some of these celebrations that we are having now is because of the foundation you laid and the work that you did. Of course, we have our colleagues from the Washington, D.C. office who have been very supportive. Some of the things you see here, they are part and parcel of all the work that we have been doing. So we really appreciate your support. And thank you very much for our director. I think we feel very happy and very comfortable working under your leadership. And we hope that if we get an extension, or if we happen to get some other work to do, we will continue working under your leadership without any complaint. Thank you very much. So having said that, I want to ask if the hotel has a representative here just to guide us on where we will have lunch, or whether we are leaving without lunch, so that we know where we will have lunch. And then after that, Sarah from Turkana, I know you have always prayed for us before we eat when we were in Eka Hotel in Eldoret. I need that same prayer so that we are able to actually have our lunch after a word of prayer. So after our hotel, please pray for us so that we can have our lunch. And thank you very much for gracing this occasion. We really value your attendance. Thank you. Yeah.
Good afternoon, everybody. My name is Cecil Otira. I'm the Banquet and Conference Manager at Serena Hotel. Just appreciate you once more for choosing to host this event here. And my brief is very short. Just to inform you how you're going to dine there. When you leave here, we are going to go to the Cafe Maghreb restaurant. You've got tables reserved under your organization's name. And then we have one VIP table. Well, when you go there, we are going to try to observe COVID-19 protocols, meaning that we have a lunch buffet, but we are requesting before you go to pick meals there, you'll wear a glove on your right-hand side, and then you will serve yourself. As you arrive in the restaurant, you've got several tables, so it means you'll be seated to your respective tables, and then after that, before you go to serve yourself, we will serve you soup on the table. So we do not want a lot of people to create queue. So meaning, please, when you go there, sit. Our team will give you juice and soup on the table. When you have taken your soup, is now when you will proceed to serve yourself at the buffet in an orderly manner. We will try to pick out the tables so that all of us do not queue at the same time, because the restaurant is fully set and it is also busy. So, but I can assure you the food is nice, and you can go for first help, second help, and third help. No extra charge. So, most welcome.
I've been requested that we can have a photo here just before. I don't know which is the best place to have a photo, a group photo. Some people want to remember this occasion. I personally don't want to remember, but others want to remember.
There's a water fountain place there. If that's not enough, then we can use our hotel gardens. So the water fountain can take maybe between 20 up to 30. But if all of you want to appear on the photo, then you'll have to proceed to the hotel gardens. We can lead you there. So you let us know.
How far is it? It's far?
It's not far, just outside here.
Okay. So let's have a prayer for food. Then as we go and go and go. Yeah. Thank you.
We can pray. Almighty Father, our heavenly God, the Father of our Lord Jesus Christ, this afternoon we thank you for being with us from our traveling period and even our arrival in this hotel. Been with us this morning. All the discussion of hearts because of our health of our people. Thank you for all the presenters. Thank you for the planners. And Father, we thank you for the interventions and the achievements of heart and the results. We thank you, Lord. The gaps of identified, the existing, and the realized ones, we commit before you. We thank for the team that has been leading us all through the HP Plus, through the
funding agents from the USAID, and many other stakeholders that have been supporting us in one way or another. Thank for all of us from the counties that have been implementing. Thank for the knowledge and the skills that we've acquired through the capacity building of many programs. Father, we pray that may all this that we've had be with us and help us to practice more over it so that we improve the health. And again, we pray that, Father, for the gaps that are existing, we pray that we may enable the HP Plus another award from the funding agents, enable them also to get more funding from wherever in this globe so that we may be able to be supported once again to realize our objectives. For the meals that are before us after this, pray for sanctification and the blessing upon it. And even our traveling back to our places, pray for your safe journey, mass upon each one of us. Thank for the convenience and everybody else here and outside, even the hotel. In the name of Jesus Christ, we pray and believe. Amen. Thank you.
Let's go. I have to wear.